Chair of the Oregon Health Policy Board and Dean of the OHSU PSU School of Public Health. Thank you so much for joining us for our March Oregon Health Policy Board meeting. Want to please ask that we have your name shown on your Zoom so we know who you are. And if you're a board member, if you feel comfortable, please share your video. The Zoom chat feature is enabled for you all to correspond with the host, but there's intra-member messaging is not enabled. So Steph, will you do our roll call, please?
Sure. Good morning. Oscar Arana.
Here.
Thank you. David Bangsberg.
Here.
Ebony Clark.
Here.
Kristen Isaacson.
Here.
Brenda Johnson.
Here.
John Santa.
Here.
Thank you.
Got everyone. All right. Well, welcome again. Sort of felt like spring yesterday. There was sun and warm air. And it was felt really special after what I would describe as a really long, cold, miserable winter for many reasons. And spring comes, at least it's not formally spring, but it sort of felt like spring. It came as we get our third effective vaccine for COVID. The pace of vaccination is picking up both in Oregon and nationally. COVID rates are continue to steadily decline in Oregon and nationally due to physical distancing, and hopefully the vaccine will give us some traction. So I believe the future is bright. So it's great to be with all of you today to do today's work. Today we will have a director update from Director Allen. We'll review some of the pending legislation for the 2021 legislative session. We'll have a discussion about our retreat, which we had recently, and a few follow-up items. We'll hear from the Cost Growth Target Committee and their 2021 work plan. We'll have a break. And after break, we'll have time for public comment. If you would like to give public comment, please send Michelle Hatfield a note either via Zoom or text her at 503-551-3881. That's 503-551-3881. And then after public comment, we'll hear committee membership work group discussion and healthcare workforce committee's proposed membership slate. And then finally, we will have a discussion on the Oregon Community Benefit Program. So we've got a full agenda today that start off with January minutes and would entertain a motion to approve the minutes.
This is Brenda, so moved.
For a second?
Kristen, I'll second.
Okay. Any discussion? All right. All in favor? Aye.
Aye.
Aye. Aye.
Any opposed? Any abstain? All right, minutes are passed. Pat, I hand it over to you. I want to just, for the board and everyone who's attending, I want to say I just really appreciate your emails that you send out to update your constituency about what's happening and sort of your reflections. So we look forward to your update today.
I appreciate that. Thank you, Chair Bangsberg. It is, it's hard to believe that Sunday marked a year from our first coronavirus case. In one of those emails, I observed that I remember it like it was yesterday, and it feels like 20 years ago. There has so much has happened, and we had a little bit of a staff gathering virtually yesterday to mark the passage of that year with some organized reminiscences of different periods of time over the course of the pandemic. And it is funny right now to think about those that first few weeks where we have an agency operations center at the Portland State Office building where the incident management team would gather, and at the end of every afternoon there'd be a sort of an end of day brief. And that room that's probably 30 by 30 would be absolutely packed shoulder to shoulder with unmasked people. The core of the response to the pandemic in Oregon, all in one room, pretty unsafely, as it turned out. We ended up obviously ending that kind of thing, and now to the point that in November we finally got everybody completely chased out of the building and are managing the pandemic 100% virtually. But remembering the pace at which information would come out or go back and forth. Lots of people talk about the CDC being confusing on masks. The one I remember is the virus airborne or not? And the other was even more than that was does it transmit asymptomatically? And there was some research that came out of Germany that said, yeah, it transmits asymptomatically. And what ensued turned out to be a really arcane argument about what does asymptomatic mean. Does it mean you never have symptoms? You only have mild symptoms? And that argument was fascinating, I guess, to the people involved in it, but caused a huge amount of confusion and a lot of delay in recognizing that, in fact, it was a big deal that the virus does transmit asymptomatically or pre-symptomatically, or whatever the exact right phrasing is. But those kinds of things sort of happening week after week after week, and then just the huge decisions that needed to be made in March, especially by the governor. Thinking about do schools close? Do we limit gathering sizes? There was one circumstance where we needed to make a gathering size decision like that day because that evening was St. Patrick's Day, and thinking about crowded bars and festivals and things like that around was a real consideration. So it's been a really, really, really wild ride, but I would continue to rather weather this pandemic in Oregon than just about anywhere else in the country or even much of the world. We observed on Sunday that if we simply had the national average rate of fatalities in the state, there would be 4,000 more deaths in Oregon than there have been so far, which is really really remarkable. And we're not sort of padding the numbers by taking the average. If you look at the median, it's about the same. It's about the same as well. So I'm really proud of everything that our team and all the healthcare workers, local public health, everybody who's been involved has done. Grateful for huge sacrifices that people have made, and for all that, we know that there is so much more that we need to do, and so much that we need to be able to do better. And hopefully we're learning things as we go and building a better system that will come out of this with better tools to be able to address health inequities, especially. Let me touch on vaccinations just quickly. We're at about 630,000 people who have 1 or 2 doses of vaccine. But 350,000 of those people are fully vaccinated. That'll kind of become the driving number now. That's pushing up above 8% of the population that's fully vaccinated. It's about 280,000 people who are in progress, and I kind of did a back of the envelope calculation, and at current supplies, that number should actually never be more than about 300,000 people. That's just how much Moderna and Pfizer do we get times 3 weeks or 4 weeks for the second dose. So really the number that will start driving the totals is the number fully vaccinated. We have vaccinated over half of 80-year-olds, about 40% of people from 75 to 80, about a quarter of those 70 to 75, and just 16% of 65 to 70-year-olds who just became eligible. I did a little test this morning and went out to Safeway's vaccine finder and was able this morning to, if I had wanted to schedule an appointment for 6 o'clock on Thursday at the Newburgh Safeway just down the road from where I live. And so I think the amount of vaccine that's now going to pharmacies is going to be a big improvement over availability of vaccine. In total, we vaccinated about 240,000 seniors. That means about 390,000 people who are not seniors. And so based on super rough estimates, there's probably still 100,000 or so non-seniors to go. And as that number gets smaller, it's going to get harder. As we think about things in smaller and smaller settings, adult foster care, homebound elderly, those kinds of things. And so we're working with local public health to basically support their strategies for getting through those populations. As Chair Bangsberg indicated the Johnson & Johnson vaccine came online actually a little bit suddenly. It was approved on Sunday and we thought it would show up on Thursday when everything else does for us to order, and they made it available Sunday night for us to order. And so we had to scramble a little bit with how we went about doing that. And it's also got the complication that it's a one-time shipment, and then we won't get any more for at least 2 weeks. And then we don't know how much we'll get after that. So what we basically did was kind of spread it out in a variety of channels, sort of to pilot a variety of different kinds of applications of the vaccine. So allocations to 4 counties, local public health, for their strategies on adult foster care and other hard to reach populations. We supplied 2 new pharmacy chains that haven't been participating so far, Walmart and Bimart, with a fairly significant amount of doses. So that really is turning on the state pharmacy program in addition to the federal pharmacy program. Then allocations generally to local public health, supplied some to the OHSU drive-up clinic at the airport. So those doses should all arrive, I think, on Wednesday at the local level and be out and available. And of course, being a single dose vaccine, it's a game changer, and the messaging on effectiveness appears to be addressing concerns that it's, quote unquote, not as good a vaccine. It's impossible to do a head-to-head comparison of that vaccine to the other 2 based on the time it was in the field for its clinical studies, much later than the other 2, the variants it was exposed to, those kinds of things. But the bottom line is at 85% effective for severe COVID hospitalization and death. It really is comparable to the effectiveness of the other 2 vaccines. So now we need to use the next couple of weeks and looking at the results of the first round that we do to really try to get a handle on what is the best application for that that vaccine. One good example of some thinking is hard to reach seniors, people who are homebound, where you pretty much have to go to them. That's really labor intensive and time consuming. And if you only need to do it once rather than go back again, that's likely an example of a good application. Other applications might include people who we think it's going to be hard to be able to administer a second dose. There's also some talk that young people might be a good target for this vaccine. We're not to that population yet, though, so we'll have to kind of think through that. Last couple of things to touch on. Our strategic planning work continues right now. The piece that we're engaged in is some really intensive anti-racism training for the agency leadership team. And in doing that work, we get to sort of increasingly difficult and uncomfortable places. The conversation we had yesterday was some self-surveying we did about, your willingness to confront racism, and we sort of grappled with the fact that our average scores were pretty good, without a lot of evidence that we're actually doing it. So that work continues. And then you're going to get a more detailed legislative update, but we completed our Ways and Means presentation phase, which went really remarkably smoothly. Often you go through that process with sort of reams and reams of follow-up and questions and things like that. And I don't think we got a half a dozen questions over 6 days of presentation. We still have a joint presentation with DHS on our shared services, which include the coronavirus response and recovery unit, as well as other shared services. But we're basically done with that first round and kind of now standing by until really the May revenue forecast and the serious negotiating about what the budget actually will actually look like. I think that's everything I wanted to quickly touch on. Be happy to answer questions anybody has.
Thanks, Pat. We have about 10 minutes for questions. Questions from the board? John?
Well, first of all, having become eligible for the vaccine a week ago, I experienced a week of this phenomenon, and it really is quite the phenomenon. I should say that I probably have a dozen over 70-year-old colleagues. And today they all have appointments to be vaccinated. But, we're white, we're wealthy, Most of us are pretty savvy. You know, it was really quite like playing a video game to figure out, you know, how to get an appointment at the mass vaccination site. You know, the diversity of approaches, though, even last week, you know, was pretty impressive. I mean, the pharmacies are different. You go in and, you know, it's one by one, no line, you know, really very traditional kind of setting. The OHSU setting, I had a couple friends who went through that who have mobility problems. You know, I like to follow the numbers. So, you know, one day last week, there were 10,000 70-year-olds who were vaccinated, 10,000, which is pretty impressive. So, you know, there's problems, especially with the diverse populations that hopefully will get corrected. I was thinking, Patrick, I have 2 questions. One, if you could just describe what this outreach process is now that, you know, you have added, which I've read about, but I think it would be good for people to hear what it's going to do. And then second, you know, I have friends saying, so, you know, where is the public forum for COVID? I know it's not here. I know it's not at OHPB. But, you know, is there a public forum? You know, some of them have concerns they want to express in one way or another. So those 2 things, the outreach process and where is the public forum for COVID?
Yeah. So the new scheduling process for the convention center is basically an invitation process. So we send names to the joint operating team for the convention center, randomly selected, and they then reach out to those names to schedule appointments. Right now, they're doing it by text alerting you that you'll get a call from their call center to do that scheduling in about a 4-day window to do to make contact and do the scheduling. I think they're gonna, I think they may be changing that up. Our biggest challenge right now is the operators of the convention center are reluctant to schedule appointments for doses they don't have in hand. Sorry about that. We think we've demonstrated that they're going to get reliable access, that they should schedule 40,000 appointments between now and the end of March, and we're tussling over that issue. But now it's basically you do wait until you get contacted and then you get scheduled, so you're not sitting at the computer trying to, you know, refresh every 10 seconds or go through a list of questions repeatedly. And of course, that's assuming that that's the way you want to pursue the vaccine. Similar to the airport, I was at a drive-through at the Nike campus on Saturday that Washington County Public Health had set up with Tuolumne Valley Fire and Rescue, where they put about 1,000 people of all eligible categories through in a real similar kind of a setup. So the diversity of places to get vaccinated increasing, I think, is probably the biggest help. In terms of the forum, it's an interesting question. I would say a couple of suggestions. One, honestly, is our Facebook page. We post daily information, you know, the daily case counts and those kinds of things, but also information about vaccinations and those kinds of things. And the comments, I read through the comments on most of that stuff most every day, which can be a little toxic at times, but it really does. There are useful suggestions and those kinds of things there as well. Also, the House Healthcare Committee has set up a COVID oversight subcommittee, and I think that's also a more formal kind of a forum, a place that people can contact that committee, provide information, and they're quite responsive to constituents, as well as then having us come report on those kinds of issues that get raised that way.
Other questions from the board? Thank you, Pat. Thank you, John. Brenda? Yeah.
Thanks for that report out, Pat. It's really helpful. I'm curious if you can also speak to language access and how we're ensuring language access are available for these distribution sites.
Yeah, so the primary vehicle for appropriate language access is 211, which then will connect people to live interpretation to navigate whatever site or system they're trying to navigate. do have some challenges with some of the online tools. We've got the chatbot that's translated into Spanish, but then beyond Spanish, you need to use to be able to use 211. We ran into an issue today with the Get Vaccinated site, where you can go through it in Spanish and you get to a place where you get a confirmatory email, and that email can only be in English according to Google. So that's a bizarre and unacceptable answer that we're trying to work through right now.
Is there currently sort of a process in case cancellations happen or no shows? How are folks going to sort of be handling that with the new system that's being stood up?
Yeah, so although it's a little bit difficult right now with the volume of people trying to make contact, 211 will be the way to do that, because they can route you to the call center for the convention center, and that call center would be the place to cancel and reschedule appointments. Obviously, right now that call center is overwhelmed, and 211 is relatively overwhelmed, but that will clear out relatively soon.
Ebony?
Just two statements, Director Allen. I just also want to thank you and your team for your leadership and courage around also really, bringing a racial equity lens that's based on the data in terms of kind of, the state framework specific to the prioritization of, kind of the various categories in terms of, how vaccinations rolled out across the state of Oregon. And I also, to that end, appreciate hearing and love the fact that, while, you all are working to consider and improve, policy and the services and support specific to being more equitable and more inclusive to meet the various and the diverse populations across the state of Oregon. Also looking at your teams and the staff, and I loved and appreciated hearing that y'all are starting to do some work specific to working from an anti-racist lens, and I look forward to kind of just hearing the learning and the growing. So thank you for sharing that and bringing that forward.
Thank you.
Any other questions or comments?
And Chair Bangsberg, I will need to step away at 9 for the governor's medical advisory panel, but I'll be back after that.
Okay, very good. All right. Thanks, Pat. Appreciate it. Thank you all for the discussion. Let's move on to our legislative update, which will be led by Jeff Grogan and Lee Stolf.
Thanks, Chair Bangsberg. Can you hear me?
Yep, very well.
And there's my colleague, Annalise. Hi, Annalise. So I'm going to provide a brief legislative update. There's some slides in your packet. Would it be helpful for me to share my screen for Michelle's going to bring them up, so no problem there. We can go ahead and move to the next slide. I want to say we're going to focus today on updates to legislation sponsored by the Health Authority, and frame that in the goals and priorities that we've already shared with you and the board and our external stakeholders. And we'll be focusing specifically on bills which relate to health policy, equity, and behavioral health. So on our first slide, you can see the health equity definition. That's okay, Michelle, I'll spend a second on this slide. The board adopted, and I think the bullet here that's maybe continues to evolve and is new is this first bullet. OHA's strategic goal is to eliminate health inequities by 2030. A little bit of a nuance in this change that you probably already heard, which is, we're not saying within 10 years, we're putting a specific time on that so that it gets more concrete. Then you can see the definition. And then the last bullet really talks about how legislative requests continue to be shaped by community input and feedback. Next slide. This is kind of our framing for the legislation which OHA is sponsoring at the governor's request this session: improving behavioral health services and decreasing behavioral health inequities, reducing barriers to access for healthcare services and reducing health inequities to our communities, and reducing health inequities in the healthcare system and realizing the triple aim: better care, better health, and lower costs. Next slide. And so we're going to kind of step through the bills and our policy option packages as they relate to the bills. I think we're going to try and keep this fairly high level, and we won't do all of the bills today. We can come back and answer any questions you may have about any bills not on this list or these bills as needed. And I will ask Annalise to lead us off, as she's our behavioral health portfolio manager.
Thanks, Jeff. So for those of you whom I haven't met before, Annalise Dolph with OHA Government Relations. I work with behavioral health Medicaid in the state hospital. So I'm going to run through these next few slides, as Jeff said, pretty high level, but of course, as with all things behavioral health related, things are changing and evolving on a daily basis. So House Bill 2086, a lot of folks have been watching this. These were the recommendations of the Governor's Behavioral Health Advisory Council that started meeting pre-pandemic and finished up during the pandemic. So things changed a little bit as we went through that process. We're in the recommendations relate to programs and services, workforce, and housing. And many of the pieces have come out and started to move forward in non-OHA other bills. And so we're in the process right now of working with other bill sponsors to come up with a package that is complementary to some of the pieces that have been brought out, if that makes any sense. But we're hoping to have a public hearing on that in the next few weeks. Senate Bill 67, actually this also is part of House Bill 2086. So you might see some alignment of these going forward. This is a bill that we're working on to improve the treatment of co-occurring disorders. And when we say co-occurring disorders, we mean mental health and substance use disorder, but also behavioral health and intellectual and developmental disability, and even trying to tackle some of the barriers in our system for folks with physical disabilities and accessing behavioral health services. So it's pretty big. It's probably going to be a phased approach. It has an accompanying POP that's part of the next line, expand community behavioral health services, to give us a little bit of money to start looking at code modifiers in Medicaid that can incentivize co-occurring disorder treatment. The community behavioral health services POP, as I said, there's several items in there that go with House Bill 2086 and Senate Bill 67. So including funding for some residential capacity, tribal behavioral health services, and other culturally based services. The SUD 1115 waiver, I feel almost like a broken record with this one for folks who have been following this for the past over a year now. We are still in the position of waiting to hear from CMS on approval on our waiver. We thought right before the presidential transition that we were going to hear approval, and we did not. So we're still waiting on that. That does have a cost to it. So that is included in our POPs and was included in the governor's requested budget. Senate Bill 66 focuses on sharing deaths suspected to be by suicide of youth between the medical examiner and counties. This is another one that might get included in some other legislation. Multnomah County is moving forward House Bill 3037, which actually has several kind of technical pieces in terms of the sharing of deaths suspected to be by suicide in order to ensure a uniform postvention response. I'll just give a little pitch for, although it's pretty weedy and involves county council kind of fighting with each other over interpretation of law. It's really important, especially as our schools start to open back up, that we are on it and we have the best postvention response we can for youth suicide. We have a placeholder, Senate Bill 68, for our System of Care Advisory Council. This is the advisory council that came out of Senate Bill 1 in 2019 to look at the children's system. That remains a placeholder. We have another, again, very technical bill, expand recovery housing for harm reduction. Currently under state statute, OHA, this is again, super weedy, OHA funding that goes to recovery housing must be alcohol and drug free, must be sober housing. And so we just want to adjust that language to make it clear that that could be used for low barrier housing. We can go to the next slide. All right, we also have Oh, that bill threw me off there. So there is a placeholder bill for aid and assist, but the main aid and assist bill that is moving this year is Senate Bill 295. It's basically a continuation of Senate Bill 24. That implementation group for aid and assist has continued to meet over the past 2 years and found some areas of the law that need to be tweaked. Senate Bill 295 is up in judiciary this week. OHA does have a $19.3 million POP that was included in the governor's requested budget. It's funding that we had asked for last short session to increase community restoration capacity. Obviously, that didn't happen in the short session. We did actually request some of this spending at rebalance. It remains to be seen if we'll get any of that, but we feel like we really need it right now. So we should know more about that in the next couple of weeks and the effect on the funding going forward. We have a state hospital technical corrections bill that relates to cost of care at the state hospital, and when a declaration, a mental health declaration may be disregarded by a treating physician. Again, pretty weedy. We have some state hospital capital maintenance and IT project asks going forward. There's Senate Bill 73 is another placeholder. This remains an ongoing topic of conversation in terms of Measure 110 conversations, in terms of OHA's outcome tracking. We have been working with the Office of State Police to try and break down some of the barriers we have now to receiving Oregon criminal records data. We haven't quite gotten to an agreed upon solution, so this remains a study bill, Senate Bill 73. But this is one to watch if we want to be tracking outcomes in our jail diversion, aid and assist, et cetera. That's a real missing piece. That's really important as we move forward with building out our behavioral health data warehouse. The following three are public health related, the tobacco sales and tobacco retail licensure in particular. And so I think we're actually going to hold off on those. So I will stop, and if there's any questions for me before we move on.
Report. Go ahead. Thank you, Annalise.
Did Kirsten have a question?
Sorry,
I didn't see you on my screen, Kristen. Sorry. Go ahead.
I thought David was telling someone else to go. Sorry. Elise, you mentioned that. Thank you for this great recap. Lots of bills. You mentioned just in the end there, walking away from the two tobacco retail-based bills. Can you say more why?
Oh, no, sorry. Those are public health bills. So I think we're just not discussing this today. I think Jeff is going to have public health come perhaps next time to discuss.
Okay.
Sorry.
Okay. Not walking away from the effort, just not describing it today.
Yes. Sorry.
Okay. Thanks. Sorry for misunderstanding.
Yeah, and we can relay any questions you have about any of those pieces of legislation, but in the interest of time, and because we have several bills, we kind of split up the behavioral health and public health portfolios today and wanted to make sure we had Annalise available to really go through all of the behavioral health legislation and can make sure we answer any questions about the public health legislation, point them at Chair Bangsberg, or come back and return to them.
Well, of course, behavioral health is public health, but we got too much to cover it all in one presentation. So why don't you continue?
I have a question, Dr. Bangsberg.
Oh, yeah, of course. Yes, Oscar, please.
Yeah, can you elaborate a little bit more on Senate Bill 69, the expanding recovery housing for harm reduction? Just kind of curious about where where it's coming from, the context, why it's important. Just love to understand that a little bit better.
Yeah, absolutely. And I apologize, I don't have in front of me, we can get you follow-up information about who our current contractors are, but this is actually an issue that some of our county partners brought us before this session, and we decided to take up as an agency bill. Because of the current language that's very clear, alcohol and drug-free, we can only fund housing projects for substance use disorder in which that's written into the program. And there is a definite need and request in the community for us to be able to use that for low barrier housing, where you're not requiring folks to be alcohol and drug free. You know, a true housing first model where we're welcoming folks into the housing and then bringing them treatment, as opposed to folks always having to be alcohol and drug free before they enter the housing. So it's not, unfortunately, asking for any additional funding for housing. It's not a fair housing provision. I know we've had some partners reach out to us and want to add some anti-discrimination provisions for folks who are engaged in medication-assisted treatment. It is really just a small change to how we can use our funding for substance use disorder housing. Does that help?
Yes, thank you.
Sorry, I missed a couple questions. I just readjusted my screen so I could see everyone now.
Okay, I'll take it from here, I think. Michelle, can we move forward to the next slide? And then I think we're one more ahead of us, right? And I just to say a few pieces about this slide. You can see several public health related pieces of legislation. I wanted to quickly cover the first two bullets regarding traditional health workers and a tribal traditional health worker, House Bill 2088 and Policy Option Package 404. Move forward a tribal traditional health worker into the traditional health worker framework. As folks know, the Traditional Health Worker Commission sits under our Office of Equity and Inclusion. And then we have a policy option package for managed care for an Indian care entity. There's no bill for that particular policy option package. Can we go forward to the next slide? I want to spend some time on this slide and talk about each of these with the board today. House Bill 2164 is at the request of the Racial Justice Council and includes a $10 million governor's recommended budget component. It will create a pilot which is being designed and developed in community with community and stakeholders to expand on the Cover All Kids model and build out further coverage for folks in Oregon who are not eligible for Medicaid or health insurance through the health insurance market and exchange. House Bill 3159 is the RealD and SOGI data collection bill. And this bill would move forward our RealD efforts and data around those components, which has been a priority of the board before, I think. And this bill is not actually at OHA's request. I believe this bill is at Representative Nose's request. However, it's aligned with the state and agency's priorities. So we've listed it here to show that work. Senate Bill 770, sorry, I was going to say 770, and that's not right. Senate Bill 70 expands regional health equity coalitions. Regional health equity coalitions are experts on the ground regarding health equity and connect health systems like CCOs with in-field and on-ground experience as it relates to their expertise in health equity. House Bill 2087 is regarding healthcare interpreters, does a couple important things, modifies legislative findings for when healthcare interpreters are required, and ensures that the healthcare interpretation is reimbursed in our OHP/fee-for-service population. The next bullet here is a policy option package, and it's for health equity innovation and implementation to right size and improve the infrastructure for our health equity work at the agency. You know, really matching that health equity goal with resources per the definition to make sure that we can keep moving forward within our agency and the Office of Equity and Inclusion with health equity expertise and information for the systems and stakeholders we support. The next bill could be of serious interest to this group and might tie to a conversation you're having later today, the enforcement of the healthcare cost growth target, House Bill 2081. This bill builds on the accountability and enforcement recommendations as recommended by the Implementation Committee for Senate Bill 889 and puts those in legislation. And then we have House Bill 2082, which is regarding value-based payments. The value-based payment conversation has been a key part of that healthcare cost growth target implementation conversation and discussion. And that group recommended principles to organize around a voluntary compact to move forward value-based payment throughout Oregon's sectors. And I think that that compact is advancing. So we're not sure that this bill will be needed given the advancement of that compact. The last bullet on this slide is reducing pharmacy costs using our leverage across the state and outside the state to create an Office of Pharmacy Purchasing and resolving some preferred drug list issues at the legislative and statutory level. This bill has not been scheduled for a public hearing yet. Next slide. And while Michelle's bringing up the next slide, I'll just flag for folks. You can go on the Oregon Legislative Information System, of course, OLIS as it's better known, and look up the status of any of these bills, whether or not they've had a public hearing, what testimony has been, what the staff measure summary from the Legislative Research Office is regarding the bills and where they are in the system. If you have any questions about them, I'm happy to answer that too, but just want to be clear that all that information is publicly available. The first bill on this slide is regarding the health insurance marketplace and moving forward our leveraging of our purchasing power by moving the marketplace as it exists now within the structure of the Oregon Health Authority. It's important to note there would be no changes to the way that the marketplace functions and operates. It would just be kind of a drag and drop moving the marketplace from DCBS to OHA. So the next bullet is regarding our fee-for-service for Oregon Health Plan and putting the gold standard for care according to care organizations and that model as the organizing principle around fee-for-service services for OHP patients and consumers. The next bill, House Bill 2079, is regarding healthcare acquisitions and mergers. This bill has been supplanted by an effort from Representative Salinas, who's working on a version of it and has been meeting with stakeholders, including the Health Authority and DCBS, to work through what a bill might look like. The next bill regards aligning the purchasing power of PEB and other public purchasers, House Bill 2083. This bill is a placeholder and has not moved forward at this time. The next two bullets here are policy option packages. The Public Employee Benefit Board and Oregon Educator Benefit Board management system replacement was the result of a recommendation from the Secretary of State audit regarding how the PEB and OEB folks can more efficiently operate the management system for their folks by combining the system and updating it for greater efficiency. And then the state public option and coverage stabilization, it really is about continuing the research that the state has begun as a result of several legislative requests over the last decade regarding a public option. This funding would provide additional research in that vein. And then the last bullet here is the Health Policy and Analytics Division placeholder technical fixes is what's listed. These are minor changes to the statute. We usually call these housekeeping, and they make minor changes to align the statute with current practice for the Health Policy and Analytics Division. Yeah, and this is just a quick summary of kind of where the Ways and Means conversation is. You can follow along with Ways and Means. Almost all of the bills I talked about just now start out in healthcare committees or human services committees in the legislature, in the Senate or House side. However, the budget conversations take place, especially for the agency and its divisions within the Human Services Subcommittee of Ways and Means. And you can kind of see a quick summary of where they're at in that schedule right now and what they're covering on the screen. And I can stop there for questions. I think I'm almost out of time, but if there are any questions about these bills or other bills, you're always welcome to write, and we can answer some of them now. Hopefully, we'll see what Dr. Santa has to say.
Yeah, Jeff, thanks. I just wanted to, you mentioned the mergers and acquisitions, and the Salinas bill is 2362. I mean, for my board colleagues, 2362 specifically mentions the Oregon Health Policy Board. And the language of the bill specifically has the language from the equity definition of the Oregon Health Authority. And recall, we had a discussion a year ago in which OHA came and presented their thoughts about mergers and acquisitions. We made comments, and then they came back and responded to those well. So I mean, I think we may be particularly interested in that bill because if Representative Salinas is able to move it forward, it will be interesting to see what elements that we felt strongly about survive and which don't, especially the equity elements.
Thanks, Dr. Santa. I think the other key component of that legislation is around cost as well. And I do agree that the Health Policy Board is mentioned in the base bill as having a part in setting criteria for the review. And we'll have to see what those amendments look like. And I'll keep the board updated as that bill evolves, especially related to the subject matter at hand and the policy board's involvement.
Other questions or comments? Kirsten?
I had a question about HB 3159, and pardon, I will look on all this. I haven't been tracking that one. But just, very interested in how we move to a better place around RealD, of course, and excited to see SOGI added and supportive of that. I guess I was wondering, we've had such challenges around RealD. Does this legislation, what is needed to help us overcome those, I guess, and is it legislative? And I agree, I understand the role of SOGI being added, so I'm supportive. It sounds great. But I guess, will this get us all the way?
I'm
that
tempted.
was a hard question to answer. I'm sorry.
No, not at all, not at all. So just for folks, I'm sorry about the acronym. SOGI is sexual orientation and gender identity. The effort is comprehensive and meaningful. It is not, around the edges. How much that is an answer for you, Kirsten. I think we've been negotiating around what will this cost and how do we do it in a comprehensive way that helps systems in the state meet the 10-year goal that I articulated at the beginning. So we can come back and talk more about this bill, but to be brief and high level, my answer would be like, does it get us all the way? I think it's probably a lifelong effort, but this is a huge step, major steps, not minor in any regard.
Thank you, Jeff. Any other questions, comments? We take a few more minutes. I think we can, there's more questions or comments. We can go a little bit longer on this. No other questions?
I will say bills continue to come out today, like 70 bills came out just today. And when the Senate reconvenes and has quorum again, we expect many more bills to also drop on the Senate side. Some kind of came out and then went back a little bit. So we know that there are some back there. So the session is still, even though it feels, to use Pat's kind of analogy about time, even though it feels like we're making progress in the marathon, they're still introducing dozens and dozens of bills regularly. And we're at the point where these bills are usually priority bills from legislators rather than the pre-session filing deadline bills. So these are, very meaningful bills to the legislators and legislature that are introducing them. And they cover the gambit. Today, we've seen several high priority bills come out. So we'll have to keep continuing to brief this body as the legislature moves forward.
Thank you, Jeff. Thank you, Annalise. Really appreciate. Oh, John, you had a last minute?
Well, I just mentioned, I think it's House Bill 2010. Again, it's Representative Salinas' bill that I think sets up a public option, but it also does some very interesting things around hospital prices and requiring participation by providers who participate in PEB, OEB, or CCOs. That's a very interesting bill, and again gets at some of the issues that we've talked about.
And there are a couple ways to kind of filter these bills as you see them and track, what's going forward and what's not. And those are, considering the legislative deadlines for when bills have to be scheduled for work sessions and when those work sessions have to take place, which is when committees vote on them, vote to approve amendments and or move them forward in the process. And there is a deadline coming up in a few weeks here, March 19th, is the first deadline we'll have, which is the deadline to post a work session, post one of those voting rounds in committee. So helpful to see, which bills make it through to that first deadline. And then when you're on that Oregon Legislative Information System, you can kind of see how the bill is evolving by checking out if it's had one of those public hearings and is being scheduled for a work session. We're getting to the point where we're going to see a rush to get those public hearings in so folks can get work sessions scheduled. So we will, by the end of the month, start to get a clear picture with what's moving forward and what's not. And then April, there's another deadline to kind of have chambers work bills. So we'll kind of keep going through this winnowing process because of these deadlines.
Thank you, Jeff. Thank you, Annalise. Appreciate the update. As you all remember, we had a really productive, thoughtful, and engaging retreat on the 17th and 18th of February. And we wanted to spend some time discussing sort of takeaways from that retreat in a discussion, and very much welcome Tara Chekhov's help to start that discussion off. And we'll also hear from Trilby DeYoung and Jeremy Van de Hey. So Tara, you want to take it away?
Great. Thank you, Chair Bangsberg. Just want to confirm that you can hear me all right. Okay, awesome. Thank you. So like Chair Bangsberg just said, I want to walk through a couple documents that I shared with you all just to confirm that the takeaways that we captured and the follow-up items resonate with all of you, and also to hear any additional thoughts or feedback that you may have since our retreat. And then Jeremy and Steph Jerem will also join in and provide some updates as we move along through today's retreat follow-up. So Michelle's gonna first pull up document 4.0, which is the retreat summary. Here, I just wanted to highlight some of the key takeaway items that we've noted really. On day one, you guys all heard from the committees of the board, and they shared about their work for this year as well as next year, some of the highlights and as well as the requests for the board to assist in their work. And this really struck up a lot of conversation and interest. And it was decided among you all that focusing on committee work should actually be the fourth priority of the board for this year through the year 2023. During the conversations, it was also noted how the staff as well as committees should work to identify those linkages between the committees, especially the committees that overlap on similar work efforts. And so we'll be sharing an update about that and a couple other items shortly this morning. And then we also discussed and highlighted really the importance of the liaison role and discussed a couple of different strategies about how we might use the liaison role to more effectively reach across different committees, again, that are working around similar synergetic work efforts. And then we also raised up the concern that we definitely need new members to be able to implement all four of our priorities as well as support the committees of the board in this work. So really, those were the major takeaways that we captured for day one. And then day two really focused on diving deeper into the three priorities that were set forth by the governor, which is focusing on the implementation of the cost growth target program, assisting with OHA's 1115 waiver renewal, as well as ensuring that health equity is weaved throughout all of our work efforts. And then of course, the fourth priority that we added from day one is the focus on the committees. And so throughout day two, it came out that there's several items and topics that you all are interested in that fall outside of these priority areas. So we came up with the idea to have a watch list, and you'll see that watch list has been included on the calendar that we'll walk through in just a moment so that we can all be reminded of these topics and these areas that the board continually would like updates on as they become available. The last request that we heard that was really raised up on day two is the need to look at excuse me, a calendar overview for the whole year as well as next year. So we'll be going through that in a minute. Those were the major takeaways that we captured. I'll just pause for a moment while Michelle brings up document 4.1 to hear from the board. Does that resonate with you? Does it sound like we've captured the major takeaways that were discussed? And is there anything missing there? Okay. Okay. Well, if something pops into your mind, please let me know. And so now we're looking at document 4.1, which is a summary of the follow-up items that we captured from both days 1 and 2. So we'll walk through these, and I'll hand it over to staff to provide updates on these areas. The first being an item that we added to your watch list, and an item that's very important that you would continually like updates on board recruitment. And we provided a brief update at the retreat, but Jeremy is going to join us this morning just to provide additional information that we've heard since the retreat. So I'll turn it over to Jeremy for his update on board membership.
Thanks, Tara. Yeah, quick update. So, I think as folks know, we did a recruitment last year and been working with the governor's office and trying to compile those applications that came in. We did a recruitment to say we did a push for applications. Applications are actually just can be submitted on a rolling basis, so it's not like there's ever a close date. But we were trying to get applicants in for the next Senate confirmation. Fortunately, it doesn't sound like the governor's office is moving forward with anybody for the March Senate confirmation, because we were still sort of trying to assemble a few applications, and we were still doing some outreach to folks, and we were expecting some applications. And so good news though is that it looks like there's gonna be another bite at the apple in April or May. And so I think we're getting pretty close, hopefully, to them landing on some folks to put forward for that next opportunity in April or May. I know that the governor's office has been reaching out to some of the folks who applied and doing some interviews with them. We heard from you all kind of 3 major themes that would be really helpful, and we've passed that on to the governor's office. Folks would have kind of more health economic experience background to help with some of the cost growth target work. I've had an ongoing need for small business or employer, want more diversity within the board, and also would like to have another tribal representative. So we've passed all that on to them. We have seen some applicants come by that have those that hit some of those preferences from the board. So more to come, and hopefully, if we're lucky, we have got some folk. We have a full board by the spring, which would be the first time in I don't know, 3 years maybe that we've had a full board. So thank you for all the feedback and that you provided at the retreat, and keep you posted.
So Jeremy, thank you for your progress on this. I just want to emphasize, when in our retreat, we talked about greater involvement of the board in committees and a more crosstalk between committees. And I think one of the major barriers for us to achieve that is filling out the board. And I don't know what we can do. Just ask you to do everything you can to sort of move things along in the governor's office, so that we can better staff the committees and create this discussion between committees and between the committees and the board.
I think we recognize that, and also recognize it's a little hard to talk about, to really fill out liaisons and things of that nature when we've only got 2/3 of the board full. So I think definitely worth coming back to that once we've got more members and make sure we kind of have things right size.
Other thoughts?
Thank you, Jeremy. And I just wanted to also draw your attention to document 4.3 in your packet. All these materials are also posted on the website, and this is the executive appointments interest form. So if anyone is interested in membership or you have someone that you'd like to recommend, please share this interest form. Like Jeremy said, these forms are accepted on a rolling basis, and we want to continue our recruitment efforts until, I guess indefinitely, but obviously the short-term goal here is to get to 9 members. So thank you. I know a lot of members have already shared this with folks that they thought were interested. So thank you for continuing those efforts, and we will also continue solicitation efforts on our end. Michelle, if you could head back to document 4.1, which is the retreat follow-up items. During the retreat, we also, during the liaison role discussion, you all decided that you wanted to update the liaison role document to state that the chair or vice chair are not required to serve as a liaison, but they may choose to at their own discretion, but that all other members are going to be required to serve as a liaison. And this component was actually already included in the document, the requirement for all members to serve as a liaison, but the addition of the chair and vice chair not being required to is a new addition. And we will also be sure to include this information in solicitation information when we're looking for new members, as well as be sure to touch on this in onboarding so that this expectation is clearly communicated to new members. And next, we're going to have Steph Jerem join us to talk a little bit more and walk through some slides on the idea around connecting committees that are working on similar efforts, and also the idea of the liaison team approach that was briefly discussed in our retreat. So Michelle, if you could pull up slides 4.4, and Steph, if you're there, you can go ahead and get started whenever you're ready.
Great, thank you, Tara. Okay. Hi, I'm Steph Jerem. I'm the director of the Office of Health Policy within OHA's Health Policy and Analytics Division. So first, speaking to the idea that came up around some of the liaison work across the committees and doing that team shared approach. We're really excited about that idea, but I think a perfect segue from what Jeremy was just talking about and Dr. Bangsberg was just bringing up, it's really hard to do that effectively when we only have 6 of the 9 board members to be able to share that work. So that's something that I think we're excited about, and maybe dependent upon who ends up getting put forward by the governor's office to fill out the board. So we're excited about that. It's a little bit on pause while we wait to see what happens throughout the spring, but that's something that I think is a really great idea, and we'd like to explore further. I am going to speak today to really think about the committee work and the board priorities overall. So just briefly, we're going to look and remind ourselves on those priorities and what the committees shared during the retreat, just ground us again in what we heard in a little bit shorter time frame than 2 hours, and then explore those connections across there, and then leave a lot of time for you all to discuss. So next slide, just as a reminder, especially for anybody who's joining us today who didn't have a chance to be part of the retreat, the board priorities for the next 2 years are implementation of the cost growth target, OHA's 1115 waiver renewal, committees of the board work, and ensuring work is centered on health equity across all of our efforts. Next slide. These are all of the board's committees. There are quite a few committees. I think this is what brought up the idea that there could be some potential in nesting them together and bringing them together more cohesively. And I think we wanted to explore today where there could be connections across all of this work. So next slide, to level set in some of the committee work, I just wanted to bring this forward. The committees at the retreat all put forward different priorities for their work, what their work plans were for the coming years. Health Plan Quality Metrics Committee, that's HPQMC, is going to spend the next 2 years reviewing measure development for equity and transformational measures, looking for approvals for metrics changes, and selecting the measures for the cost growth target program focus. Metrics and Scoring Committee, which is a subcommittee of HPQMC, will be working throughout the next year on the 2022 incentive measures and targets, monitoring the pandemic impact on performance in 2021. And then next year, we'll be trying to move beyond the medical model. And we had a lot of conversation about that at the retreat, about how intriguing that is, how cutting edge, how we really need to move past that and think through how we can measure social determinants of health and equity. The Public Health Advisory Board, the FAB, is going to spend this year working on the health equity review policy and procedure, which they have a great document on that already, and wanting to put that into the implementation phase, as well as supporting implementation of the State Health Improvement Plan, which is also known as Healthier Together Oregon. In 2022, they'll be working on the Public Health Strategic Data Plan, which is really exciting work, and then updating the accountability measures and continuing ongoing implementation of the SHIP, as well as the 2021 to 2023 public health modernization investments, if they're passed. The Health Equity Committee, or the HEC, will be updating the health equity definition and continuing to serve as a liaison between the Health Policy Board and the Racial Justice Council, which is a group that the governor has brought together. They'll also be supporting waiver renewal and the cost growth target program. So this is a great example of where the HEC is helping across multiple committees, across the board, across our state government function as well. They'll continue in 2022 with some of that liaison work and some of the support for our major policy development. The Primary Care Payment Reform Collaborative is working currently on their VBP primary care adoption and collaborating with the cost growth target work, another example of where our committees are coming together. And we'll also be adopting the health equity framework into their existing work. In 2022, they'll have a progress report to provide information to you all on, and we'll be promoting and monitoring implementation of behavioral health and primary care integration payment models. Next slide. As we continue with all of our committees, the cost growth target, a major focus area of the board for the next 2 years. The committee itself will be looking at accountability legislation, which you just heard about. They'll be reviewing the cost growth data and drivers, monitoring for unintended consequences, which is a phrase that we need to think thoughtfully about how we're going to describe that, and make sure that if we're talking about actual racial and ethnic consequences and impacts, that we're calling those out specifically. Advancing the data use strategy and developing guidance for performance improvement plans and future governance. The Healthcare Workforce Committee will be spending the next 2 years developing and completing the equity framework, as well as the doing some member listening training, evaluating future charter topics, and continued recommendations and use of the Healthcare Provider Incentive Fund. The MAC, which is the Medicaid Advisory Committee, will be monitoring CCO 2.0 implementation. They have a subcommittee that's going to be focused on improving Oregon Health Plan consumer experience. They'll have recommendations out in late 2021, and will be supporting OHA and the board with some of the requirements of the 1115 waiver renewal. And finally, the HITAC, which is the Health Information Technology Oversight Council. They are doing a ton of great work on community information exchange, supporting efforts in legislative session, understanding the implications for HIT in our state, working on some federal interoperability rules coordination, recruiting new members, and restarting the statewide health IT strategic plan update. So tons of really incredible work that's happening in the committees underneath the board. I bring all that up for the next slide to really say, we are interested in connecting across the committees. All of that work we do not want to continue to happen in silos, and you can start to see glimmers of where these committees are connecting across on their own or recognizing opportunities. I think our staff has been hearing this. We had some really positive experience working with Dr. Bangsberg and with Oscar on connecting the HEC and the FAB in the fall, and I think we learned a lot from that, and we have ideas for how that can move forward. So we wanted to look today at just 2 examples focusing on board priorities to say, here are some committees that we know are likely going to need to be connected in different ways. So what that could look like. So for the next slide, we have the cost growth target. So we know that's an actual committee of the board, but we know that there's shared interest in this. So as we just listed in the committee work, we know that the Health Plan Quality Metrics Committee, Primary Care Payment Reform Committee, and the Health Equity Committee will all have roles and connection points in the cost growth target. And I think this is the strongest priority alignment. It's not to say that other committees wouldn't also have input or ideas, or we might be able to make connections across those. I think when we look at these shared interest groups or affinity groups, you could call them different things, I think there's a lot of different ways in which we could actually support work across these committees, whether it's the committee staff. I think that there's also opportunities, when there's a webinar, making sure that all the committee chairs are aware of the webinar, that they can attend, that they can collectively ask questions, that they're presented with the same information. I think when we get to a stage where we have liaisons for every committee, we'll be able to have the liaisons meeting to discuss where there's alignment, where there's leverage points. And I think that there's a role for the board and the board members to be, when these come up to the board, to be able to sit there and have all of the different liaisons and the board members to be able to be identifying some of these connections across the committee. So the next one is around the waiver, and similarly, we know that there are opportunities with our cost growth target. I could go to the next slide, Michelle. Thank you. To the Medicaid Advisory Committee, the Public Health Advisory Board. There's a lot of information in the State Health Improvement Plan, for example, that has to do with SDOH. Great opportunities to consider how that folds into our Medicaid program overall. That's been a continuous focus area of Oregon's transformation, and health equity, of course. So again, just thinking about really what would the board want to see? How would the board envision these connections actually happening? So yes, we can move to the discussion question. Thank you, Michelle. So I think, this is only 2 weeks later, so certainly not, hard and fast drafts of what this could look like, but I think we just wanted to get the ball rolling, follow up on some of the committee discussions, and make sure that we're really grounding ourselves in what that work looks like, and say, first of all, does this capture what we discussed at the retreat? As always, what are we missing? And then I think learning from all of you, what are other ideas on how these committees could be connected, especially across these 2 topic areas that are primary, front and center for the board?
Great summary and synthesis. Thank you, Steph, Tara, very much. Comments from the board, Brenda?
I just really want to commend the work. I think you've synthesized the discussions really effectively, and it reminds me about the power of what it's like when we can identify gaps in our internal functions, and then think about like what a future reality might look like. I specifically appreciate the notion toward how we engage our committee chairs, liaisons, and OHA staff, like that kind of trifecta approach, and looking forward to the day when we can kind of pull everyone together to have this very conversation, because I'm feeling a little bit lacking, without the rest of those other kind of core component and pieces in place to be able to contribute much more. But I'm imagining maybe it's something we could begin to schedule, in May or so, when we think we've got new board membership and the liaison stuff is kind of locked down a bit, that we can re-engage this particular conversation with a larger group. Yeah.
And I want to acknowledge for the board members that this is stepping it up for us a bit. I mean, when Oscar and I were working with Health Equity and Public Health Advisory Board, you know, there's a fair amount of phone conversations that required scheduling and calendaring and making sure they right people came together. The staff at OHA was superb at making that easy for us. But nonetheless, you know, that crosstalk takes time, it takes energy, and it takes intention. I also think it's really important. But I think we should walk into this recognizing that that's, you know, that investment's ahead of us. John?
Yeah, that was very helpful. I think it captures what we discussed, but of course, you know, there's more to come. I liked the slide where each committee was listed, because I think what was listed for each committee was what they are the leader on. You know, for the committees that I am the liaison to, I mean, metrics and scoring is the leader for selecting 2022 incentive measures. They make those decisions, we don't. Now, of course, they do so with the governor and with the health authority and all. But I think as we move forward, it would be good to indicate, again, using the, you know, lead, collaborate, when each of these committees is in a leadership role. And then what do we do? Do we collaborate or support or communicate as we work with them?
Thank you, John. Other comments? We have also, we're going to have a discussion right here about health equity and the waiver and the calendar.
Yeah, I have a couple more updates from the retreat when we're ready to move on from this, but want to make sure if there's any other comments or ideas to share, that we create some space for that.
Just one quick comment. I really appreciate all the work that's gone into this in such a short amount of time. It's hard to believe that our retreat was just only a couple of weeks ago. So I really want to commend OHA staff for the quick turnaround on all these documents and this work. I really appreciate it. I do want to acknowledge that as we sort of prioritize the committee work as one of our areas of focus, yes, it's going to be, more work in the near future. We should just sort of like accept that and embrace that. But ultimately, I really believe that in the long run, this is going to really streamline and align and make all our work a lot easier and more effective. So.
Well said, Oscar. Thank you.
Great, thank you. Anyone else with comments right now? So we'll go ahead and keep moving along here with the retreat follow-up items. Next on the list was we had a discussion about the health equity priority, and you all had decided that within our guiding principles for decision-making document, which is numbered 4.5, we added a question in there, bullet point, and when you pull up the document, you'll see it's bolded. So all added text from the retreat is bolded to make that clear for you. But we added this bullet point here that in all board decisions, we must apply an equity lens and ask how the work impacts health equity. Does our decision advance efforts, have a neutral impact, or deter health equity efforts? Really as a reminder to keep us focused on our health equity centered approach, as well as our priority. And you all also asked that each time we are going to make a decision within a meeting, that this document is also accompanied with those materials to keep us reminded of these values that we've placed in this document. Does that sound right to everyone? Does this addition represent what you all had in mind?
It does for me, Tara, thank you. And I'm curious, Chair Bainsberg, and if we're thinking about adopting this as a formal board action today or at some future date.
We hadn't planned on a vote, but I think if OHA, if a vote would help to endorse this, I would welcome that guidance from OHA.
I have one comment, around this. I think, yes, the board has the responsibility to sort of like ask these questions about every decision that we make, sort of apply this equity lens. And I also think that as staff is bringing stuff to the board to make those decisions and do those votes, that staff has a responsibility of also aligning, sort of answering that question. And so for us to easily see how that fits, I think I'm supportive of, if we wanted to do the vote, I'm supportive of it, but I'd still like to see sort of this framework built out a little bit more in terms of asking the question, does this advance our efforts? Is it neutral or does it deter? Like, I just feel like there's a little bit more that then maybe there's more to see there.
John?
Yeah, I mean, this document is fine with me, but I must admit, as I read through it a bit, or in the language around consensus, I mean, I think it's absolutely great to try to drive to get to consensus on all decisions. But, I mean, I think it seems reasonable to me that a person, may disagree. And allowing them to register that, even after, all these attempts have been made to resolve their disagreement, seems like it should be possible. With still a requirement that, the decision's been made and that person agrees to support it. I mean, I've certainly been involved in companies where everybody gets their chance to say their piece. But when the decision's made to go forward, you've made the commitment to support it, even if you disagree with it. And so that just got to me a little bit. So I just mentioned that.
And I would just add to that, if we all agree all the time, then we're either not handling enough, the issues aren't complex enough, or we're not diverse enough in our ideas and what we're bringing to this. And so I think, having the diversity of ideas is really important. And I learned so much from all of you, and expanding the board, expanding that diversity. There will be times when there is a thorough, thoughtful, engaging discussion. But at the end, maybe a difference of opinion, but common support. Or a difference in interpretation.
Thanks for that. I absolutely agree. I would like to move, well, before I move approval, I'd like to recommend that we tighten up the language in the last paragraph, which is basically to solidify and bring this forward for a formal board action. Purpose for doing so for me is less about how our OHA staff is really supporting our board and more about how we hold ourselves accountable for the elements that we've outlined here. And then as we think about onboarding new board members, I think having this document will be really important to put in front of them. So with that recommendation, I move approval on the board decision-making process.
Second?
This is Ebony, I second.
Sure. Any discussion? All in favor?
Aye.
Aye.
Any opposed? Any abstain? Okay. So this passes with the recommendations of, editing and tightening up the language again a little bit more, and then maybe we'll look at it, or we'll just have OHA send it out and we can see the new language. I don't think we'll have to vote on it, revised language.
Certainly. Thank you, everyone. We will do that. Just wrapping up the last two items here. Another follow-up item from the retreat was just the request to receive the link to the current OHA waiver, which is included in this document here, 4.1, with the emphasis that we discussed there was some interesting background information on the Oregon Health Plan that starts on page 20. So you're welcome to read the entire document, but we had specifically called out that read at your leisure. And then the last document that Michelle will pull up this morning regarding the retreat follow-up items is 4.6, which is the draft 2021 to 2022 work plan calendar. I'll walk through some of the highlights of the calendar, and certainly I welcome any additional feedback or comments. This calendar reflects information that we heard from the committees during their day one retreat presentations, as well as the work that we discussed in day two around the priority items. And you'll see here that the work plan calendar, we're looking at our monthly agenda items, and each agenda item is color coded to represent its linkage to our 4 priorities. So you'll note that several items link to more than one priority. And then we've also, for each agenda item, linked it to the board's role. So is that a leader, collaborator, supporter, or communicator role? And then we also have a column on the right side of the board's role, and that's for any notable events that are occurring. And certainly more information to be added here, but this would include items such as our educational webinars, major milestones within the projects and priorities that we're following, legislative dates, items like that. So certainly if there are ideas or requests, I'm sure I did not capture everything. We will be adding to this and consider it a living document. And certainly, Steph and I will be taking this to the lead staff of all of our committees in our monthly meeting tomorrow to confirm that the agenda items and dates are still accurate, because we know, especially with the waiver, this work plan is developing and it's somewhat flexible. So know that we'll continually share an updated version of this document, but wanted to give you a roadmap so that you all knew where we're headed for the remainder of this year and into next year. And then also I'll call out at the top of this document here is the board's watch list. So these are, again, the items that you want to stay informed on that are outside of the priority. So we will do our best to let you know about webinars, documents, information as they become available on these 3 items. So we have OHA strategic planning efforts, behavioral health, as well as COVID. Specifically, the lessons learned was called out during the retreat. And then Michelle, if you just want to keep scrolling down the document until you reach 2022. We also have a draft of what the 2022 work plan will look like. And right now, this is just by organized by quarter. And as we get more information on the work, we will be plugging those in and breaking this out into monthly meetings. But I did want to draw your attention to the notable events. So next year for 2022, we will have our retreat on February 1st, and the chairs and staff had agreed at our last planning meeting that this would be a standing appointment, that from here on out, we will use our February meeting date as our retreat date, so that that is held on the calendar. We don't have to scramble to find availability, and that it gives staff a little bit more than 5 days to turn around retreat documents to all of you all. So I wanted to call that out. And then also that we heard you all, and we know that there's a strong desire to return to out of area meetings. And so we have that plan for 2022. And you know, if that's available sooner, we will certainly adapt. And then we'll be working on a hybrid meeting schedule because we also heard that you guys wanted the option to have both in-person and virtual meetings. And when we do that, ideally we'd like everyone either virtually attending or attending in person. And then Michelle, if you want to just keep scrolling down, there's some supporting documents I have down here. So you'll see lots of acronyms in the work plan, and most of those are acronyms of the committee. So they're listed here, as well as the committee's priority work areas and current board liaisons. And then again, reference to our framework of roles, those 4 titles, as well as definitions. And then at the very end, there are links to the OHA's website for current meetings, as well as historical meetings, where you can find all of the meeting materials, recordings, and closed captioning. So I'll pause there for any thoughts, comments, reactions. We heard that you guys all wanted something like this, where we're looking at monthly agenda items that are related to our priorities as well as roles. Does this capture the request, and are there any edits, feedbacks that you'd like us to include in this document as we continue to revise it?
Truly a tour of organization. Comments or suggestions or revisions from the board? Oh, John, and then Kirsten, thanks.
Yeah, well, I get that, distant meetings are out until 2022, which is okay, it's understandable. But especially as we get into the cost growth target work, would there be opportunities in 2021 for us to reach out virtually to various audiences and get some sense of what they think of that, and get some advice, either audiences that we know well, the CCOs, for example, or other audiences that are more patient and consumer and equity oriented. It just seems like those travel meetings were always a good way to hear from real people, and is there some way we could do that a bit in 2021?
And I was going to cover this a bit when we get to the cost growth target. We can talk about it an hour later, but I would be interested in other folks' comments. But it's something that's been on our mind as well. I think, especially thinking about the part of the cost growth target work is building towards an annual public hearing, and thinking about, but that official first public hearing is not going to be for some time. So there's some things that are kind of the lighter end of that start to engage the board with key stakeholder groups and communities. So we love other board members' thoughts now, or we can talk about it when we get to the cost growth target work plan.
The CCO listening sessions were very productive, I think, and I think they framed our discussions and our work. So maybe to replicate something like that. Kirsten, you had a comment?
I just want to say I really appreciate the color coding and highlighting the board's role in these different parts, and thinking about the year in advance, knowing what's coming at different times. I don't know, I assume a lot of work went into this document, and I think it does a great job communicating a lot of information. So thank you. I imagine the watch lists box might need to grow. I think would be my only, that looks kind of small for how I imagine that evolving. But this is really great and appreciate it. Thank you.
Great, thanks. Certainly if other items need to be added to the watch list, we can certainly do that. I think just want to be mindful not to put too much on your plate, as we are going to be becoming more intensely involved with our committees and liaison roles. But certainly we will provide you as much information as you can absorb. So if there are additions to the watch list, please let us know. And then John Santa, just regards to your previous comment, certainly if in-person meetings are allowed, this year, we will certainly adapt to that and work with you all to implement a hybrid model of in-person and remote meetings like you all requested.
You know, the Golden Globes did it. It was a little oddball, but they did it.
I just want to give voice to also really appreciating the level of work that went into this. It absolutely is the kind of structure I was imagining when we were talking about it at retreat. And I'm thinking about the other feedback would be where we have statutory requirements to report to the legislature on certain reports or events that we hardwire those deliverables in this structure as well. And then just to build off of what John was saying around the cost growth target kinds of intersections when we know we're going to have more, and I use the word listening session gently as I say that, but I'm also thinking of a similar structure around the 1115 waiver, you know, that while we have waiver update for every month, there may be opportunities during the course of this year where we take a, as you said, Tara, a deeper dive in those subjects, and whether it's in the board education side, you know, or those webinars, or whether or not we have like broad-based community engagement, that we somehow flag those in this document. So we've got our sight set toward larger events in essence. Thanks.
Certainly, those are great suggestions and we will include those. Thank you.
Oscar, you have a comment?
Yeah, probably similar to what Brenda just said, but you know, at the risk of sounding repetitive, I think I'm trying to connect the dots of what I'm hearing from the other comments from our board members. One, you know, in 2020, we sort of launched this very kind of intentional community engagement approach where we listened to various different communities regarding, you know, COVID-19 and the impact. So going back to this idea about the watch list growing and our commitment that we wanted to continue doing these very intentional community engagements, community, you know, engagement might be something to add to the watch list, and sort of figuring out how to add those to the calendar in a very thoughtful approach, and how they connect to our priorities like the waiver and cost growth target. So sort of figuring out when does that happen. And again, so because we're not trying to replicate too many different things, but we're just trying to be very thoughtful about how we execute them.
Good point. Thank you.
Chair Bainsburg, I actually asked a question. So I'm curious, I'm worried about the amount of sincere community engagement we can really jam in 4-hour meetings. I'm just curious if board members would be open. I mean, I think we can maybe do a combo of maybe find some opportunities where the board's directly hosting, but I'm also wondering if board members would be open if we've got other opportunities that are out there where we can say, we're gonna do some community engagement around the waiver, invites for outside of a regular board meeting, if that would be maybe another way to kind of strike a good balance there.
I think, go ahead.
Yeah, Jeremy, I would suggest that that's our preferred method, that we first start with the communities that are already meeting and inserting this conversation to the best of our, you know, their interest and our ability to staff those conversations, where that action is already taking place, and that we are invited to join in on those conversations as it makes sense. That be the first kind of modeling priority. And second to that would be those that are specific for the board, you know, and that it's not kind of one or the other, it's kind of a both and.
Really?
Yeah, and just to add a third possibility, we have committees, as we've seen, that will be closely affiliated with working on waiver and working on cost growth target. And those committees may have ideas for engagement or opportunities for engagement that we'd also want to highlight for the public and then hear back about and invite board members to attend.
They could host the engagement.
Exactly.
In the listening sessions you did for CCOs, many of them were in the afternoon or some in the evening. And I think that was really helpful too, to make sure that we're structuring it around people's time and availability outside of the board. And we often had 2 or 3 board members attend those. I think it certainly informed my understanding. I think others as well, just to hear what people were talking about and raising as concerns. So build it and we will come.
Okay, sounds great. And then just to wrap up, wanted to just ask one last time, were there any other takeaway items or follow-up items that you all were expecting to hear today that perhaps we missed. Just want to make sure that we have fully heard all of your recommendations and ideas as we continue to build out our project documents here. And certainly if ideas or thoughts come up later, always feel free to email me or anyone on the OHA team. And call me too.
Yeah, and you're all welcome to quiz me on my 300 pages of Medicaid. See if I really do it. All right. Thank you, Steph. Thank you, Tara. It was great. Great work.
Thanks, everyone.
So Jeremy, we're moving on to cost growth target discussion.
Yep, let me just pull up my document here. So you should have attachment 5, which is a overall work plan for the year, broken down into 3 columns. The left being proposed topics for policy board meetings throughout the year. The middle one will be topics for the implementation committee, which will continue on throughout the year. And then the far right column is kind of other implementation milestones. There'll be other bodies that are engaged between Health Plan Quality Metrics Committee, rulemaking, technical advisory group. So try to map those all out right here. This obviously does not capture the conversation that we just heard a little bit from on kind of more points of engagement with stakeholders throughout the year on the work. So I think we can take that back and think about that. It also doesn't. We talked kind of at the retreat about whether to do kind of a light version of a public hearing at some point this year, and we haven't quite nailed it down. So would love some feedback on that. But as you go through this. Starting, obviously today is just a review of the overall work plan. In April, we expect bringing an initial framework for monitoring equity and unintended consequences. I know there was some concern around the term there, but we'll keep working through that. Wanted to get some initial feedback on the framework before we set the Health Plan Quality Metrics Committee loose too far and get some early feedback from the board. And also the Health Equity Committee will be involved in that as well. So expect in April will be a draft framework around that monitoring component. Can we scroll down, Michelle? Great, thanks. In May, we were expecting at least one opportunity here for maybe bringing in some stakeholder community panels. We have 2 reports that we're wrapping up that give us some baseline information around cost and utilization. One is something that replicates some charts you've seen before. There's a organization called the Healthcare Cost Institute that puts out a utilization and price annual report of what's happening with utilization and price generally within the healthcare system. And we've created a similar version of that analysis in partnership with them using our state all payer claims database. So it'll give us a pretty good deep dive into what's been happening with price and utilization. Secondly, have looked at hospital prices. I think folks have seen there's been a lot of attention around organization called RAND that has done a lot of work on what's been happening with hospital prices nationally. The challenge with both of those national reports is that they tend to only use a pretty small amount of Oregon claims. So Oregon is included, but it's a pretty small sample size. So we wanted to do similar types of analysis, but with a much broader set of claims from our all payer claims database. So we'll have 2 reports out, kind of broad utilization costs as well as what's been happening with hospital prices. So we thought this would be a good opportunity for the board to spend some time on those reports, do some work around costs and potentially invite a panel in and be able to engage and can talk about what that would look like. Why don't I just run through the rest of this and then we can come back for discussion. June. Oh, can you go back up, Michelle? Sorry, to June. June and July. June, we would expect a report back from the Health Plan Quality Metrics Committee on their component of monitoring. in July, a report back on what happened with the legislative session and Senate Bill, House Bill 2081, which is the accountability mechanism, as well as bring forward a draft template or guidance for what performance improvement plans would look like. Those are kind of the first, maybe the second step of accountability, sort of transparency, then performance improvement plan. Again, potentially another opportunity for a panel or some engagement to get some external feedback on that as well. Why don't we scroll down to August? In August, we expect bringing an update on what we're calling the data use strategy, which is kind of the broad strategy for what types of analysis OHA is going to be doing both regularly and sort of ad hoc. And we're expecting this to be a pretty heavy topic of the implementation committee this year. So that's why it's a little bit later, but we'll provide an update to you all and see if that data use strategy is hitting the mark in terms of what types of analysis you'd like to be seeing as part of this program. We would also expect to bring a charter forward for the successor committee to the implementation committee and start and get some feedback from you all on membership and the charge and scope of that work of that committee on an ongoing basis. In September, again, bring back any changes from the charter and hopefully get approval at that point. In October, have an update on accountability and implementation of accountability mechanisms, and then in November, tentatively thinking about value-based payment compact work group, and again maybe another opportunity for a panel in there. So we've got some opportunities. Oh, excuse me, and then in December, an update on. I guess actually now I look at Sarah wasn't able to make it today. Now I look at this again. I think she maybe was thinking December was sort of the soft hearing. She should put it in her data update. But I think what she was anticipating is that we would, whatever data we've sort of accumulated throughout the year, that kind of gives us a sense of a baseline, that we would be able to do some type of, whether we call it a public hearing or just a panel around that data towards the end of the year. So that's sort of our overall flow. Would welcome thoughts, questions, feedback.
Brenda.
Thank you. This is really wonderful, Jeremy, and I'm thinking about, given our last conversations around committee-to-committee overlap, if you're envisioning that this kind of a calendar would also create opportunities to really explicitly call out the other interconnections, with Health Equity Committee in particular, or with a primary care payment collaborative, that those checkpoints get mapped out. So that's one sort of question and thought to consider. The second, I suppose, is, whether or not, maybe this goes back to our previous conversation with Tara and Steph, that we could think about these work plans for each committee, again, mapping out the entire annual calendar, these like deliverables and milestones. So 2 thoughts and questions.
Yeah, thanks, Brenda. And I guess I didn't run through the other columns, but they're very clear asks and deliverables, both from the Health and Quality Metrics Committee and the Health Equity Committee, and some of those are in the right column. We can certainly bring more detail if you'd like on that, but yeah, both of those committees will be pretty heavily engaged in this work throughout the year. It'll be a pretty high priority for both of them.
Brenda, I have a comment based on your comment. I think one of the things that I remember seeing or mentioning is the idea of this global charter across all committees. So this idea around this kind of work plan, annual work plan calendar for all the committees, that could be something that could be part of that global charter.
Thanks, Oscar.
Any other concluding thoughts? Kirsten? Yeah, go ahead.
Thank you for this update, Jeremy. I was curious if you could say more about what you envision as a panel. Are those people from the committee, experts, or people from maybe a breadth of committees that are giving us kind of, how do we have a holistic interpretation or response to some of the information that we're receiving?
Well, to be frank, I think we could really use some input from the board here. I think we could certainly bring in folks from the committees, like we tend to usually do, I also heard, I think from John's comments and something I had sort of envisioned was that this is also an opportunity to engage with external folks. I mean, obviously not the entire healthcare system, but throughout the year thinking about, are there a couple reps from commercial insurance, or a couple reps from hospital or health system, or a couple reps from, other parts of the delivery system. So we'd love some guidance. We will obviously want to map that all out right now, but I think if you've got guidance of, we would like to hear, we would, kind of would like to be able to have some stakeholder panels throughout the year, mix them throughout that. I think that would be helpful. If you prefer more kind of on the committee side, and hearing more directly from the committee, I think that would be helpful guidance as well. And certainly, I said stakeholder. I'm saying stakeholder broadly. I mean, that obviously can include consumer advocates. It could include community partners. It could include other folks as well.
I think I would, or Chair Bainsberg, may I respond? I think it would be great to think about those panels as opportunities to really give breadth to our understanding and application of that work. And so I appreciate your definition of stakeholder being that like very broad picture, because I think we do need to hear from different aspects of the industry as well as those who are impacted by these cost trends, living it in their lives. And so I think having that a breadth of voices on that panel would be useful.
Go ahead, John. Yeah.
Yeah, I think one thing to think about as I think about a panel, I mean, there's some pretty sophisticated folks out there on both sides of the political spectrum who are, interested in data and big data. And my guess is they would be happy to weigh in, but their first comment would be, we need to see the data. And we need to look at the data, and we'll give you our take on what the data says. So one of the issues will be, to what degree do outsiders have access to the data? And I know that's a very tricky issue.
Well, it's really not that tricky when it comes to the cost growth target. I mean, the data is going to be pretty relatively straightforward and public. I mean, people would be like, insurers are going to be calculating trends and sending it to us, and it's going to be out there. There's going to be deeper dives we do with the all payer claims database, which is, several hundred gigabytes, if not terabytes of data. It's and obviously includes personal health information. So it's not like we can just sort of blow that wide open. But what we do plan to do is be really transparent about any algorithms that are part of the calculation, so that folks can pick those up and do the same types of analysis. And we expect that we will be putting data sets out there that are obviously can be public, that don't have personal health information. So it'll be kind of a mix of all of those things. But I think, John, to your point, I mean, I would think that, as we're thinking about in May having, a broad price utilization analysis or a hospital price analysis, I mean, certainly we could invite folks in, that we first have sort of said, here's, I mean, it would be an opportunity for them to kind of get their reaction to an analysis. One idea just kind of thrown out there, and I'm shooting from the hip, so I don't know if this is a good or bad idea, but Kirsten, as the liaison, one thing we could do is see if maybe you'd be willing to kind of help maybe liaison between the board and the committee and thinking about what the right mix of kind of panels are, and help us kind of build those out as we go throughout the year.
We should move on. I think we are going to take a 10-minute break, and we do have public comment to return to. So it's 10:25. So let's return at 10:35. So we'll see you all at 10:35. Thank you, Jeremy, and everyone. Appreciate the discussion thus far. Is it Tara or Steph? Are you introduce the public comment? We have Deb Elder, who would like to make 2 minutes of public comment. Michelle, thank you. like to welcome Deb Elder for public comment.
Just a reminder, if you're on the phone, you may have to press *6 to unmute yourself.
Thanks, Sarah. Deb Elder, can you hear us? We can't hear you at this point. Maybe you can text Michelle or send a note in the chat to Michelle. We can come back to help sort out the audiovisual problems. So Deb, please send Michelle a message in chat, and we'll try to figure out what's happening, and we'll come back. Apologize for that. So the next item on the agenda is an update from the committee membership work group, previously called the Committee Diversification Work Group. We have some materials in our packet today, and we'll have a discussion from Seth Jerem, Brenda Johnson, and Mark Overbeck to share how the work group's interim recruitment guidance and how the work group is supporting committee membership requests before final guidance documents are available for the work group. After Seth's update, Brenda and Mark will talk through the Healthcare Workforce Committee's proposed membership slate that will come to us with support from the committee membership work group. So Steph, are you taking us from here?
Yes, I believe so. Okay. Bright sunshine in Oregon is blinding my computer right now. Okay, so what we wanted to go through today was just to really speak to the updates on an effort that has been, that was brought up throughout the summer and fall of last year around membership recruitment, retention, and engagement of committee members in relation to the Health Policy Board. We brought together an internal work group in December of last year. We had a charter that we approved and finalized. I believe it was included in the retreat materials. That was a cross-agency work group to be really thoughtful about all of this. We did have a lead staff person who unfortunately left the agency to take another opportunity at the end of the year. And so with that, we began an effort to recruit a health equity lead contractor. This was determined just because we did not have the internal resources to be able to commit to the level of work that we think this really requires to be able to think about this more collectively. And we thought this would also be an opportunity to bring in somebody with expertise in thinking through how we can be taking everything we've learned, everything that we're trying to achieve, and have a little bit of a external view on how our agency is functioning, and to be able to say, okay, here's where our gaps are, as opposed to recognizing, I think sometimes you can get into a pitfall of how it's always been done. So we really wanted to push ourselves outside of that. So that application deadline closed on February 26th. The work group, the internal work group, will be reviewing applicants and selecting the contractor in the next 2 weeks, which we're really excited about. The work group in the meantime has been focused on a provisional guidance document. So that is attachment 7. And thank you, Michelle, who has that up on the screen. The provisional guidance for membership recruitment of the OHPB committees was an effort to provide some recruitment guidance to maintain the essential functionality of the board committees, especially as this work has been extended a bit because of our change in staffing model. So we try to say, what can we do in the meantime? We recognize that some committees still need to function. We also recognize that this came at a time where some committees were in the process of open recruitment and had recruited some really excellent members, and we didn't want to stall that unnecessarily if there was an opportunity to engage those people and bring them onto the board. So we developed that provisional guidance document, which is attachment 7. And then we've been working with our lead committee staff on all of these documents. The current version that we're looking at today is going to be discussed in detail at that group, that meeting tomorrow with all of the staff of all the different committees of the board. So this provisional guidance, I'm just going to walk through at a high level for you. So the first step in the provisional guidance for committee staff and others who support members were to first consider whether or not you can pause membership. So really say, like, is this really essential to the ongoing functionality, expertise that you need on your committee, or can you just take a pause and maybe function at a, not a full slate of your committee while we develop the more lasting guidance? So if you can pause, we said, please wait until you can, until we have the final guidance document available. Otherwise, we can continue. So the next thing was we wanted to employ the work that the Division of Equity and Inclusion has done in partnership with the HEC to develop a gap analysis. So the gap analysis really looks at not only demographics across Oregon, but looking at it regionally. And it was a really great tool that we asked them to employ to focus and target their recruitment and outreach efforts on those gaps that they have in the committee. Each of the, if a committee wants to move forward in the process with adding additional membership, we ask them to provide a summary of the gap analysis to this internal work group, and then also provide additional information about the membership request that may not be reflected in the analysis. And that could be about, like, perhaps they need a particular type of provider that they're really missing that voice, or perhaps there's been a priority that's been put in front of the board and they don't have expertise around that. And so those are the types of things that we said, this can be another useful perspective. In order to move forward, they also needed to provide a copy of the committee's charter and application materials. I think this is an example of the type of thing that we have so much room for improvement on across all of our committees. As you know, some of the committees are appointed by the governor, some of them are appointed or by the board. There's different materials for different applications. It doesn't come to a central space. Sometimes Tara and I have access to those, sometimes we don't. It's really pretty confusing. So we asked them to provide some of the background material for that. And then really think through and be able to present on some of these factors. So what is the minimum number of members needed for quorum? Do we need to maintain quorum? So that's certainly a driving factor in here. How many members are currently on the committee? How have membership numbers changed in the past year? So any reasons for those changes? Are we starting to see a decrease in membership? Is there a reason why? Have we seen a significant increase? Is there a reason why? What is the critical work or deliverables that we need to address before June, which is our target date for when we'll have this final guidance? And in some cases, it may be related to some of the expertise that they need in order to accomplish deliverables before then. What are the consequences to the work plan if positions are not filled? Are the vacancies essential to committee discussion? Again, going back to certain roles that people play within committees. And then whether or not the committee has the capacity to fully support full inclusion. So this has to do with language access, ADA accommodations, alternate formats, staff capacity, and resources to support that. I think this is another one of the areas that we'll be doing an assessment on as part of what this work group will look like overall. And I would say I don't know that our committees are truly offering that right now, and that may result in a limited set of people who feel comfortable enough to apply to our committees. So once they have all that, the committees can go forward and meet with the committee membership work group. That work group is serving as an advisory board for moving forward and discussing recruitment strategies. This is not to replace the role of the board, but to say, you know, we think that you've done your due diligence here. We understand what the need is. We do recommend that we feel comfortable with this moving forward to the board, for example. There are, in step 2, we have a number of different recruitment and membership strategies to use. This is just a small taste of what we're hoping to see when we bring on a contractor that can be really much more, have a much broader scan of what our techniques are, what are our best practices, how to do this. This was really just pulled from the best practices of existing members who support outreach and engagement. And then again, using the committee membership work group as a review board. So bringing that back together after we've cleared you to go forward and recruit to say, okay, now what are your results? That page 3 is just the OEI gap analysis in more detail. I encourage you to look at it. It's really a fantastic resource. And so with that, I mean, I'd like to pause there and answer any questions that anybody may have about this work group, about the process, about the current provisional guidance before we move to Brenda.
Just real quick, Steph, could you also give us an update on how the committees have done in the collection of Real D and SOGI data to help us understand the composition? Because I know that we don't want to assign,
So this has actually been incredibly challenging. We did not have a very good return rate on our Real D data information collection. I think one of the challenges that we found is that without an identifier, it is hard to do follow-up. That isn't just a blanket, like, if you haven't done it yet, please do it. We also don't understand necessarily whether or not people are intentionally taking the step to not respond in the same way that somebody may say that, I'm not comfortable with this data being collected, or if people are just too busy, don't have the time, that kind of thing. So Tara, I don't know if you happen to have the numbers off the top of your head. There you go. So this was the Real D data request. This information was included in the retreat materials, which I know that there were many, so we can go back and pull that forward. But here was the response rate and participation rates for the different committees. And we made multiple pushes. We made pushes from Tara and I, the individual staff that support the committees have made pushes for this, and we really struggled with this. We also have some challenges that we learned about in terms of if you change membership, again, because we don't know whether or not there's no identifier related to the Real D information. As you change membership, you would have to go out and ask everybody to complete it again because the Real D data would have changed across the committee. So we have a lot of lessons learned and really need to pause and figure out what and how we can do this more effectively going forward to achieve what I think are the goals of the board in understanding what the demographic data really looks like. Other questions? Feedback on the process?
Have you had a conversation with the Health Equity Committee about how to best collect this data? I noticed that their response rate was 15%.
Yeah, we've talked about this collectively as both a committees of the board staff group and this membership work group. The staff for the Health Equity Committee sits on both, and I think recognizes some of the same challenges that we've had about busy committee members and not being able to take the time to do it, and then really having a challenging time following up and identifying the people who haven't been able to fill it out yet to say, it's a little bit of a, I don't know the right metaphor here, but you know, I'm blanking on it. Wide push that is not at all targeted. So, as I said, a lot of lessons learned. Definitely something that we're going to continue to have conversations about within the work group, especially when we bring on the contractor. And I think part of this is also one of the reflections that we have is Real D certainly gives us a certain picture of the demographics that we're interested in, but it does not complete the entire picture of what I think matters to board members from some of the conversations we've had. And so even some things about like region of the state or expertise and lived experience and other aspects that we value when it comes to a diverse pool of candidates beyond just Real D. So I think while we do have low rates, I think that this is not the only piece of information that will drive, you know, the understanding of diversity on our committees.
John?
I don't know if you can put that table back up, but what did I see correct? Do I remember correctly on that table? I mean, we're talking about 180 committee members.
That's correct.
This is a big population. And you know, as I read this, I mean, these are essentially jobs. And you're trying to fill 181 jobs. And you know, people live lives, and so probably a third of those people turn over every year because they're moving. We just had a member at Metrics and Scoring announce that he's taking a job outside of Oregon, and great member, he's gone. So gosh, that's a lot of work. And you know, too bad you don't have the equivalent of a kind of human resources recruiting person. Because you know, this is a unique pool of folks that probably constantly needs to be grown and nurtured, and you know, that's pretty impressive.
Thank you, John. I think that's pretty accurate. I would say in addition to that, it's 182 volunteer jobs.
Right.
So, you know, that comes with its own challenges and equity challenges as well. And I would also just, you know, as a reminder, thinking about this, we decided to focus this initial effort on health policy board committees, 182 people, a lot to think about there. And I mean, am I wrong in saying we have over 200 across our whole agency? Committees, not members, I mean committees. So this is a phenomenally significant effort to really reevaluate how we do this work, how we recruit and engage, how we continue to keep those people on the committees, how we ensure that it's an inclusive environment. I think there's training for staff members that needs to be done. I think that's all the work that we hope to have in our recommendations about how to move forward on this. And it probably will be you know, quite the path that we need to follow in order to get to where we want to be with that. And there's a lot of moving pieces there. But I think you've identified some of the challenges we face.
And you know, I think we oftentimes think, oh, well, you go to the hospital association and go, we need a hospital person, or the OMA and we need a doctor person. But you know, you get what you pay for. You have a committee member who does have a bias and has a conflict, and you would like more of those 181 people to have been chosen, you know, differently than that, for the most part. You know, wow.
I kind of, you know, I remember at the retreat, we talked a little bit about, you know, the need for like a dedicated, you know, executive appointments, or sort of similar to what the governor's role is to focus on this work. I mean, I think, you know, obviously we have identified health equity as one of our priorities. The governor has identified health equity as a priority. I wonder if we could sort of like use those to sort of say, we need this resource, we need a dedicated, I'm glad that we're getting a contractor to support this, but I think it's, you know, beyond a contractor. I think it's a dedicated high level like position that's focused on this, since it fits within our health equity and our committee prioritization work over the next 2 years.
That's great feedback. Thank you, Oscar. And we are doing some work to rearrange staffing within Health Policy and Analytics Division to try to find some resources to do what you're talking about, and in anticipation of saying, we're going to have this big effort, we're going to create some processes and changes to how we do our business, and we need some kind of centralization. I think that it doesn't achieve some of what you're speaking to, but we're certainly recognizing our upcoming needs for some of this.
Jeremy, you.
I just wanted to thank John for his comments on recognizing the amount of work that this is for staff. I think even as we've had new committees come up in the legislature, I think we've really taken a step back and thought, I don't think we've been putting the right fiscal on these for what the long-term effort is. I mean, it feels like for each committee, it's pretty much a full-time staff, at least one, if not multiple. And I think there's also a trend, and just kind of putting this out there, that I've seen over the years of, there's always a lot of excitement around a brand new committee. A bill just passed, there's a brand new program, there's this thing where there's a bunch of engaged folks and they want to be on there, and then they get through their first year of work, and then it's like, okay, what's the next thing? And those initial excitement kind of falls off, and then it becomes really hard to kind of recruit. And so I think that's an issue that we kind of perpetually are in, of not only are we constantly recruiting for these, but they aren't always all the new shiny object. They're the new thing that everybody wants to be engaged in.
John?
Yeah, and you know, Stephanie, as I read this, I remembered, 2 years ago, the first equity measure failed at health plan quality metrics. It was brought to a meeting where the committee was in transition. One of the co-chairs had left. There was another vacant or two positions because of that transition. It failed by one vote. And, so I think you got to keep these committees populated. And I think you're going to run into, there was already a comment from one HPQMC member about, well, are we going to start on the cost control stuff, and then midway through, a third of us are going to be replaced? Is that a good thing to do? And she has a point.
Brenda, are we ready to move on to your Mark's presentation of the healthcare workforce membership slate?
I'm ready. Mark, I see you just joined us on camera. Did you want to give the board a little bit of a recap of your process? Clearly in our materials, we saw the framework that our committee has gone through. And then when Mark is finished, I'll propose the slate.
Okay, great.
All right. Thank you, Brenda. Good morning. I don't want to take too much time to verbally say what is in the written material, but I might make a few comments and just share some insights as one committee staff member with the board in terms of going through this process. I appreciate that the Healthcare Workforce Committee is the first committee of the board to undergo this new process. And to be honest, at the beginning, it seemed like an inconvenience. And maybe that's where everything useful begins. That, we just want to get the committee staff, but over the course of time, as this went on, it became apparent that being able to speak about the mission of the committee, about who we need to have be at the table, to be thoughtful and reflective, not just that the committee, quote, looks diverse, but it's authentically reflective of closing the gaps. And I think in the memo that's in your packet, you can see the gap analysis that we provided for the work group. And in the end, it was a very helpful process. I would not have expected that at the beginning, but it was truly a helpful process. And over the course of time, I've come to consider that perhaps the work of who you bring to the table, understanding what kind of a table you need to have to hopefully keep those people there, is much more important than we may give credit to in terms of being able to develop the product that we need to develop to advance the state in these policy efforts. Just very grateful at the opportunity to take several steps back along the way over the past few months. Say, now, is this group of people reflective? And I am grateful that, and some of you may remember, back in 2013, 2014, when I first got connected with the Healthcare Workforce Committee, what I recall was a 16-member committee with 13 Caucasian individuals on it, almost all of whom had very advanced degrees and credentials in medical, and that was good. I do believe that over the years we've developed a more perfect, it's not perfect by any means, but you can see in the memo also, we reached out far broader to the simply, well, let's go to the hospital system and see, who do you have? We scanned internally with the Oregon Health Authority. We went out broader to stakeholder groups, I think in a very thoughtful way, and we had to justify our case to the membership work group, which was a very constructive exercise. So I think those are my reflections, that the gap analysis is there, and I'm hopeful that you will recognize both the process and the outcome of our work in a way that you can see does honor your commitment to have your committees be reflective of the state's population, if not even more reflective of the kinds of voices, expertise, backgrounds we all want to have at the table to be crafting the future of our healthcare system. Thank you.
Thanks for that, Mark. So I'll call your attention to document 7.2 in our packet. This is the spreadsheet that shows the composition for the committee. And I'll call your attention actually to the table that's close to the bottom of the document, where it looks at the committee and Oregon census demographic data. And you can see the balance between what the committee composition is proposed to be and what the Oregon state demographics are. And with that, I think when I saw this come through, I was pleased with the progress, and I think Mark speaks to the notion that we're also recognizing we're incomplete, that this is a work in progress. And as this work group that Steph just gave us a highlight for finishes its work by June, we'll look to continue to have this conversation back to the committee again as we think about elections for the end of 2021. And the next slate, of renewal candidates that we bring to the board. So with that, I'll call your attention now to the top of the document, where we can look at the proposed reappointments and the proposed new members. That's the board action for today. And really excited that both the demographic mix, and the improvements that you see here, but I think also the layers of expertise that are represented. There are significant shifts in thinking about medical assistant training, thinking about oral health, and bringing greater technical expertise in the industry to that committee. So without further ado, I'd like to make a motion that we accept the slate of candidates, both the proposed new members and the proposed reappointments for board consideration.
I'll second that. Dr. Bangsberg, you're on mute.
Any discussion? I just want to make sure that we have an opportunity to share any thoughts, impressions before moving forward to a full vote. Any thoughts, impressions, concerns?
Yeah, just a quick comment. One, I just want to really thank, the staff and our board liaison for all their work and attention into the recruitment process, and helping move this committee in the right direction. Like Brenda said, this work is evolving and we'll continue working on it as we move forward. I can see significant progress already, so this is really great and exciting. One comment I'll say as we continue to move forward is that I noticed that in our gap analysis, we're sort of looking at using the census as a way to sort of determine demographics, and the census is notorious for undercounting communities of color. So I just want to make sure that folks are kind of flagging that, and that we should not only strive to sort of be representative of the populations that we're representing, but also we should embrace the fact the communities that are most disproportionately impacted, when we're sort of looking to build out our committees. So not just about racial demographics, but also those that are most disproportionately impacted.
Well said, Oscar. Thank you. Any other reflections? I also want to thank Brenda and Mark for moving forward with us and your progress. I know it's been intentional, important work in terms of building this committee. I just wanted to hear from other board members if there's thoughts or concerns that want to raise.
Oh, can everyone hear me okay? This is Ebony.
Thanks, Ebony, yes.
Yeah, I just, appreciate while we're working to kind of support policy legislation, as we're working to also support, community, the CCOs, providers, so on and so forth. I do appreciate that we're also doing our due diligence in holding ourselves accountable to the same expectations in terms of, how we further equity and voice. So I'm just, glad to see that we're, also walking the walk. So thanks.
Thank you, Ebony. John?
Yeah, well, I think this is terrific. I mean, in the old days, I think, Mark, the question would be, whose Rolodex did you get access to? I mean, how'd you find all these people? And, figure out, that they were the right fit, so good work.
Kirsten, any thoughts before we move forward to a vote?
Not that already hasn't been said, so.
So I think took the temperature. I think we're ready for a vote. All in favor? Aye.
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 Any opposed? Any abstain? Did we get, Ebony, did we get your vote? I think you're on mute. Ebony?
Perhaps she stepped away.
Or you might have stepped away. Okay, all right.
I do think we should let John know that 1985 called and wants its Rolodex back.
All right. All right. Great. Well, thank you, everyone. We do have public comment. We have Deb Elder, who I think is waiting in the virtual wings. Deb, can you hear us? And we'd like to share your public comment for 2 minutes. Deb, we can't hear you yet. So can I apologize? I really appreciate you being here to provide public comment.
Chair Bagensberg, I'll connect with Deb again to see if she can join, but her testimony was emailed to the board members this morning and is posted on the Oregon Health authority is the board's website under today's meeting materials, attachment number 6, if people want to review that. But I'll connect with her, and please go ahead and continue.
We'll carry on and then we'll check in again.
I'll just real quick, Deb, if you happen to be on a phone number, I think if you press *6, that might unmute you. Give it one more shot. Okay, looks like we can continue.
All right, move on. My neighbor's mowing his lawn. It happens every Tuesday. So I'll make this introduction brief. We'll discuss Oregon's hospital community benefit program from Amy Claire, Health Analytics and Research Data Manager, and Steve Renzoni, a Health Analytics Hospital Reporting Program Analyst. And they'll provide an update of the Oregon Hospital Community Benefit Program. Trilby, would you like to provide some introductory comments?
Yes, thank you, Chair Bainsberg. So good afternoon, board members. I know it's late in the agenda, and I would ask you to rally here and stay with us because this is really a very exciting program that we want to share with you with this last agenda item. During the 2019 session, Oregon passed some landmark legislation in House Bill 3076. I don't know if that's top of mind for anybody at this point, but it was a bill that had really been 7 years in negotiation, sponsored by Representative Salinas, that made some changes to the community benefit program and charged OHA with creating the infrastructure to implement these changes. And I do want to say how appreciative we are at OHA of the time and expertise that many organizations and individuals have contributed over the last year or so in helping us to shape this program. We ended up launching the program in the midst of a pandemic that really it's to the credit of these organizations that they were able to stick with us through that, and to staff that we were able to do all the consultation that we did nationally to really develop this program. But, you know, in the midst of a pandemic that highlighted health inequities and the vital link between the conditions in which we live, grow, work, and age and health, it really couldn't be better timed to launch a program like this. So what I want to do is just say a few words of introduction about the program before I turn it over to Amy and Stephen, so that I can make some explicit links for you all between the program and your priorities of health equity, the cost growth target, and waiver development. And I think you'll particularly see those links around the waiver's goal of increasing opportunities for targeted investments in social determinants of health. So what you'll hear about is how hospital community benefit includes several things. Financial assistance for individual patients, that tends to be the biggest chunk of spending. Also, the unreimbursed cost of Medicaid services, so the shortfalls that providers experience between their costs and the Medicaid rate. And then most significantly for our OHA equity goals, there's also community level investments in the social determinants of health. That's part of the community benefit spending. And so to carry out the legislative mandate from House Bill 3076, OHA was required to establish minimum spending floors for community benefit for each hospital or hospital system across Oregon. And we really were required by the legislation to call out investments that address the needs that are identified by the hospital's community. So there's a very tailored approach to hospital investment in community benefit. It's really the first of its kind in the nation. And we did get significant national media attention as we were developing the program and now with its launch. So to sum it up for you all, really there's two words that best express this program, I think. And I think staff, we've come to a shared understanding of what the program really enables us to carry forward. And that's a new level of transparency around this kind of spending, and also opportunities for alignment in these investments. So in transparency, I mean, what you'll hear about is a brand new reporting template that asks hospitals to identify their community benefit activities that are addressing social determinants of health or health equity. So we will be getting a window into the type of investments that hospitals are making in their communities. And you all might want to think about how this kind of spending could be a component of what you hear about in your hearings on the healthcare cost growth target. And as you begin to analyze spending that's occurring across different levels of Oregon's system. You'll also hear from Amy and Stephen about a new community benefit dashboard that OHA has developed, which will allow the public to really see those investments that hospitals are making into community benefit, what categories of investment these are, and they'll really be able to inform the opportunity they've got for public input into the specific spending floor for their hospital or hospital system. So it's really a whole new level of information that we'll have available and that we'll be able to make available to others. And then with alignment, what the bill does is really require hospitals to report how they are working with CCOs and public health agencies to identify and address community needs. And then the bill also requires us at OHA to consider that need and that alignment with the need as we look at the spending floors. So clearly community health assessments, community health improvement plans, and also the health equity plans that CCOs develop are going to be a tremendous resource for us at OHA as we look across these investments. We'll be setting floors based on this information, and we will be reporting on hospital spending and this coordination across needs assessments, which will really give us an opportunity to encourage alignment and shine a spotlight on those opportunities to leverage dollars from multiple sources. And we think that's going to have a lot to do with increasing the impact of social determinant spending in communities across Oregon. So as you can see, we're excited about the program. I'll stop here and turn it over to Amy Clary, who is the Research and Data Manager for HPA's Office of Health Analytics. We were very lucky to get her leadership on this, as she was previously with the National Academy of State Health Programs and actually leading their national look at community benefit work. And Stephen Renzoni, who is our Senior Data Analyst managing hospital data for OHA, and he's really been the leader behind the considerable consultation and development work for this new process. So Amy and Stephen, I'll turn it over to you.
Great. Thanks so much, Chilby. Good morning, everyone. Thank you for having us today. As Chilby said, I'm Amy Clary. I manage the Research and Data Unit in the Office of Health Analytics, and I'm delighted to speak with you today about this exciting and innovative program. I did want to mention that we've set aside some time at the end for questions and discussion with all of you, so we look forward to that. So rest assured, there will be time for that. Next slide. Terrific. Thank you. Under the IRS policy that undergirds our community benefit program here in Oregon, hospitals are expected to invest in their community in exchange for their tax exemptions. Just a bit of framing here to set the stage for you. The Affordable Care Act back in 2010 had implemented a requirement for hospitals to assess the needs of their community and implement a plan to actually meet those needs. One thing, though, that the IRS does not do is it does not require a minimum level of spending on community benefit. And so this is an area where states can take the lead. And that is exactly what Oregon has done here by implementing a minimum community benefit spending floor. Next slide, please. And Oregon, honestly, has been leading in community benefit for quite a while. Our cost-based community benefit program was innovative back in 2007, and our reporting reflected that. In 2015, we launched a new standardized format for our public-facing reports, and that, as Trilby mentioned, has been updated in our exciting new interactive dashboard, which we'll talk about later. The innovation continued in 2019 when HB 3076 included activities, you can see that in red there, that address health disparities and social determinants of health in the very definition of community benefit, which is very interesting and exciting. So we're moving to that interactive online format that we will use as a tool to encourage the kinds of community benefit investments that align with the the OHA priorities that Trilby mentioned, priorities related to equity, to costs, and the social determinants of health. And next slide, please. So HB 3076 also increased financial assistance. It instituted a minimum spending floor, more on that, more on both of those in just a moment. And it also eliminated Medicare shortfall as a category of unreimbursed costs, even though that still counts for federal reporting. OHA rules allow hospitals to meet their community benefit obligation by spending in any of the 10 categories that Trilby had mentioned before, categories that encompass unreimbursed care, health professions, education, and research, and then also the kinds of direct investments in communities that are likely to address equity and upstream health improvement. And next slide, please. So just a word about financial assistance. This is a really exciting part of 3076 that can sometimes get lost in the fanfare over the minimum spending floor, but just a note on financial assistance. HB 3076 increased financial assistance in a way that benefits not only the uninsured, but also the underinsured. So under this new legislation, folks with low to moderate incomes and high deductibles and copays can get some relief. So for instance, if a person has a household income of say $44,000 a year and they're hospitalized and say they have a $2,000 deductible, under this, they're eligible to have a minimum of $1,000 of that deductible waived under this policy. And any amount that is waived by the hospital then is counted as charity care for purposes of their community benefit reporting. So that's how that ties in. Okay, next slide, please. So as mentioned, the program really seeks to encourage investments in health equity and the social determinants of health in alignment with all the other good work that's going on internally and with our partners. And so to that end, we will be launching a new reporting template that asks hospitals to identify their community benefit activities that address the social determinants of health or health equity, including at a population level. And we've crafted that so that it will ask about activities that address individual health-related social needs and activities that address systemic issues, root causes of health, population health, and health equity. And that reporting will give us a really unprecedented window into the types of investments hospitals are making into that area. And we look forward to having that data and making it available publicly as the program matures. Trilby also mentioned that our program rules bake in alignment with CCO's local public health, other programs and partners. And we look forward to the CCO health equity plans that can help us align with that too. And so we really see this as a holistic approach where we ask for this kind of nuanced, granular reporting. We see where the community benefit investments are going. We make it available publicly in what we hope will be really user-friendly ways to access that data online so that people can see what they're interested in. And all of this work, these priorities of addressing health upstream, of looking at community investments, all of this work has the potential to impact cost. And this program, I think, will be another important line of sight into hospital finances. And so operationally, our team works closely with the Sustainable Healthcare Cost Growth Target Program, and we look forward to that alignment maturing as the program goes forward. So at this point, you're probably thinking, I wish they would tell me more about that minimum spending floor that's getting all the media attention. And so with that, I think this is a perfect opportunity for me to turn it over to Stephen Ranzoni, who, as Trilby mentioned, has been the staff lead on building this effort. And so Stephen, back to you, over to you.
Hi, thank you. And by way of quick introduction to the board, my name is Stephen Ranzoni, and I'm a hospital policy advisor here at OHA, and I program manage the hospital reporting program, which includes this community benefit program. And so I'm happy to talk in a little bit more detail about the minimum spending floor program in itself. And so when this passed, we became the 6th state here in Oregon to have a spending requirement of any kind. And of those 6 states, we are the only state that actually specifically crafts a spending floor that tailors it to the hospitals. Any other examples you see across the nation are usually blanket requirements such as a percentage of net patient revenue, which is a common thing to see, in as much as 5 can be common. In our program, it successfully launched here at the beginning of the year, January 1st, 2021. We stood up our rules after a lengthy and involved public engagement process. Not to say that in a negative sense, but to say it in much as that we engage as many stakeholders as possible. We talk to experts from academic settings as well as in OHA and with hospitals and public stakeholders to build our rules and launch our program. Next slide, please. So the bill set forth requirements that OHA had to build around, a framework, I think, so to speak, with which we were to design this program. The first set of requirements on this slide is the factors that we had to consider when designing a minimum spending floor program. They're listed on the slides, the major one. In quick summary, we had to consider the historic performance of hospitals. We needed to consider the financial position of hospitals. We need to consider the degree to which they're spending and social determinants of health, taxes paid, demographics served, and factors such as that. Next slide, please. The bill further required OHA to seek public involvement and to seek advice from experts. And so we did that. Specifically, we sought out advice from George Washington University and Johns Hopkins University, consulted those people, and engaged extensively with hospitals throughout the process. And then last requirement of that statute was that we were to allow hospitals to have a say in the manner with which the spending floor was applied to them in terms of their organization. And so what that means is a hospital could choose to have the spending floor applied to just itself as an individual hospital and any clinics that it owns or controls. Or likewise, it could choose to have it cover an entire health system. So there's multiple hospitals, multiple clinics that one spending floor applies to, or really a lot of stuff that could be in between. And the power resides within the hospital to choose how that spending floor would be applied to it. Next slide. So we took the requirements of the bill, what we had to do, and one of the first tasks that we did was we set forth a set of guiding principles of how we wanted this spending floor program to look like and how we wanted this methodology to end up being shaped. And so our key points that we used in designing our approach was that first was the understanding that financial assistance shouldn't be limited, right? And so we really wanted to respect and represent that financial assistance is need-based. As Amy covered previously, it's specified in statute even, the level to which a hospital is required to assist patients. We wanted it to apply to all the categories of community benefit. Specifically speaking, Oregon recognizes 10 different categories. And so spending in any area should be applied to the spending floor. We wanted it forward-looking. We wanted it prospective, so hospitals knew in advance what their spending obligation would be. We wanted to leverage and use all the existing data we had. We didn't want to be in a situation of trying to stand up and create a new reporting system on top of this program. And then we wanted to keep it simple, scalable, and flexible such that hospitals themselves could readily calculate their floors and plan for it. And then last, but certainly not least, we did not want to create any kind of formula or program that would enforce a negative trend or allow for community benefit spending to decrease over time. Next slide. And here it is in all its very colorful glory on this slide. Through that entire process, roughly 18 months of work, we landed at a methodology that I will just talk about really quickly. We'll go into each one of these factors in a little bit more detail. But we calculate the spending floor by taking a hospital's 3-year average of their unreimbursed care spending. To that, we add a direct spending net patient revenue percentage. I'll explain that more. And we modify that amount by their operating margin. Then to calculate the second year of their spending floor, we take the first year and we adjust it up or down based on their 4-year average of their change in net patient revenue. And so that method increments up or down, theoretically, the spending floor based on their trend in patient revenue. Next slide. So to start getting into the methodology in a little bit more detail, that first component we talked about was that unreimbursed care component. As we mentioned earlier, we really don't feel this is something that needs to be limited. And so all we wanted to do was represent what we see as the expected trend or the ongoing trend of unreimbursed care for that facility. And so that's its place in this formula. We take what they have been doing, we average it, and we set that as an expectation for the future. And so unreimbursed care in itself, to be more specific, it includes the community benefit categories of unreimbursed costs of Medicaid, charity care, other public programs, which primarily would be support of TRICARE, VA, or Indian Health Services, and then subsidized health services. So next slide. We wanted to represent direct spending, which includes categories such as community building, health professions, education and research, and the type of spending that much more closely reflects social determinants of health. The way we decided to do that was look at historic performance in these areas, ratchet it up slightly, and then set it as a percentage of net patient revenue. And so that is determined based on the urban or the hospital type. So DRGs have a 1.5% net patient revenue percentage that they're expected to contribute to direct spending, while a type A and a type B hospital has an expectation of 1%. And so said in other terms, we take their most recent net patient revenue, we calculate what 1.5% of that is for DRG hospital. That is their expectation for direct spending, which reflects those categories. Next slide. We want to take the financial performance of the hospital into consideration in this formula. The bottom line, so to speak, of all financials is essentially the operating margin, right? That's how much money they made after due to operations, or in other words, it's the profit margin, right? And so our formula has a list of tiers based on their average operating margin over the past 3 years. If their operating margins are high enough, we'll actually upwardly adjust that direct spending percentage. If their operating margins are not robust or actually losing money on operations over time, we will downwardly adjust the direct spending component of the methodology. Okay, and then that is the methodology in a nutshell. Our rules and how we roll out this spending floor program is entirely based on the fiscal year of the hospital. In Oregon, we have 5 separate fiscal years. Legacy Health Systems is about to start their fiscal year. It begins on April 1st. So we have already issued their initial spending floor, and we're in the process of doing that. We will keep rolling out additional hospitals as their fiscal years approach. This slide kind of summarizes the process that we put forth in rules. It begins about 90 days out from the start of their fiscal year, where the hospitals have to identify to us how they want to be grouped. And then that starts a process of OHA delivering their initial spending floor, hospitals having an opportunity to respond to it, the public having an opportunity to comment on it, all before we arrive on a final spending floor for the next 2 years by the first business day of their fiscal year. Next slide. As we mentioned, Trilby noted in her opening comments, and Amy has mentioned it already, transparency is the #1 priority of this program. We have been active in reshaping our website to support this new wealth of information that we're going to start reporting. I will encourage everybody to go to our website as soon as possible. This slide has a couple of screen captures from how it looks now. You can go there right now to see the initial spending floor we have assigned to Legacy Health already. Grand Ron is the next hospital that has a fiscal year coming up. Their spending floor went up yesterday, so it can be reviewed as well. And on top of just being able to first, see the spending floor, see the calculations that went into it, and have an opportunity to read any public comment that may be issued. We've also created a space, and we will be rolling out further some hospital-specific pages where all the financial information we collect on hospitals, all the community benefit reports that we've collected for hospitals are readily available, easy to find, and easy to view. Next slide, please. We have created rules that allow for hospitals to request a modification or in the event of financial hardship, even a waiver of their community benefit minimum spending floor. In commitment with the transparency process, any requests that are made for us to modify the floor would be made public. They'll be put on our website. The public can comment on the request for modification. Any and all modifications will be on a case-by-case basis. It would be data-driven based on the financial metrics that any hospital would provide to us to justify a need to change the spending floor from what we assign. Next slide, please. And looking ahead to the future of this program, we do have challenges and opportunities, of course, like with everything. Our immediate challenge right now, of course, is the impact of COVID-19 on the hospital financial trends. We did build this program in a pandemic. We were aware of it. But I think I speak for everybody when we hope that COVID-19 isn't a routine thing that we face in our lives. And so, we built the program based on historic performance of a hospital. And so COVID-19 is a short term, it's a period effect that we just need to work around. And we will be doing that as the future as we apply future spending floors to hospitals in this year's. Another challenge that we face is the growth of unreimbursed cost of care. It becomes a dominant percentage of all community benefit spending that happens on hospitals. And as the years advance, it's a trend that keeps getting larger. The percentage of total community benefit that's attributed to unreimbursed cost of care is getting larger, while the percentage to direct spending is getting smaller. And that's a trend that we need to pay attention to and possibly monitor in how we want to address that in the future. This program also gives us new opportunities to really address community benefit spending in Oregon. Trilby noted them. Amy spoke to them a lot, but really it's a tremendous opportunity for public engagement. It's a tremendous opportunity for collaboration with our multiple partners. It's a tremendous opportunity to bring CCOs and hospitals together to be working on shared community health strategies and addressing communities in need in Oregon. And that's really so much of the power of this program. The new data, the new narratives that we will be collecting from the hospitals that explain their community benefit programs in more detail, that talks about how they're working on social determinants of health. All of this becomes great information for our future in talking about discussing community benefit and how we can help our communities. So, and next slide, please. And so while the spending floors are effective in fiscal 22, and we won't, have data on them for a number of years now, it doesn't mean we don't have great new things to show you. We just recently launched a brand new community benefit Tableau dashboard. It's an interactive dashboard where you can go in and see the current community benefit reporting data that we have. It's explorable by groups. We group it in, statewide trends, hospital type trends, and you can also investigate by individual hospital. And so we have a dashboard link here. You can also access it by going to our website, and we'd like all of you to go and please explore this data. This dashboard is pretty cool. I do say so myself. And next slide, last but not least, community benefit resources. I would just, to keep it simple, I'll point everybody to our hospital reporting page. Again, we've been active in changing it and expanding it. The link's right there. You can always just go to Google as well, type in Oregon Hospital Reporting Program. It's going to be your first link. That's where you're going to find that Tableau dashboard we just showed you, where we're going to start collecting all our summer reports, index it by hospitals. We'll be rolling out those hospital-specific indexes as their community benefit spending floors are coming up. You'll get access to raw data, spending floor announcements, and things like that. If you have specific questions, you've got a list of contacts here before. We do have a program, just a general program mailbox, as well as Amy and I's emails below. And with that, we're done and open for questions.
Thank you, Trilby, Amy, Steve. Appreciate the presentation. Let's open up for discussion. I can start off with Oh, go, Chris. You go ahead. You go ahead.
I don't want to take too much time here because I feel like I know I've been watching this program develop and I'm just so thrilled. And I guess I will start by saying that not just this dashboard on this particular issue is beautiful, but Stephen, you and your staff have made some really incredible upgrades to OHA's data platforms over the past month, and it does make the data much more accessible and understandable, and it just kudos to all who made that happen. Nice job. And I just this program is incredible to watch OHA Oregon stand up in the midst of a pandemic, and I just want to underscore that the expansion of charity care eligibility in our state has a tremendous impact on that very vulnerable population that doesn't qualify for Medicaid, but still is paid low enough that you can't afford benefits or to use your benefits. Speaking, Amy mentioned the underinsured, and we've seen this make a difference in people's lives already. And the relief of just sharing the information of hey, there are options out there. It's okay if you get ill, is powerful and an important support structure that Oregon has created. So thank you.
Thank you.
I have a question about your, oh, go ahead, John, please go ahead.
Two questions. Is there eventually going to be reports that the individuals who are benefiting from this reflect the populations that from an equity point of view we think are in need of being recognized? That's number one. Then number two is, where are the hospital foundations in all of this? I mean, many of the hospitals have huge foundations, and we hear very little about them and what those foundations are doing. Are they in play here to any extent?
Oh, that's such a good question. I'm going to answer the easier of the two first, which is about the reporting. And one of the things that we're asking hospitals to report on when they submit the narrative that enumerates their spending on equity, social determinants, upstream health improvement, we ask them to describe the demographics of the population served, demographics, and also place-based factors. So if they have a place that was impacted by wildfires, et cetera, how do their activities benefit that? And so there's going to be a lot more qualitative information than we've had previously on how these hospital investments are taking steps to address equity and serving previously underserved populations. So we really look forward to that. The hospital foundation question, that's a good one. I mean, we framed our slides with referring back to the federal policy on hospital community benefit, which really looks at the tax exempt entities of the hospitals themselves. I mean, that's a great point. I don't have a whole lot to add to what you're saying right now, since the program's focused on hospitals and their clinics more so than the foundations. That's great context. Stephen, anything to add on that?
No, I'll just say you answered the question, Amy, that the language of the bill and the focus of the bill was hospitals and the hospital affiliated clinics. We actually even have further guidance in our hospital reporting program that disallows hospitals to be claiming pass-through payments. Really, the community benefit does need to originate from the hospital. And so, to be very blunt, no, hospital foundations are not included here, and it is a missing factor.
Sometimes in my interactions with healthcare delivery, health systems people, I think I find sometimes a narrow view of what a social determinant of health is. For instance, access to help with transportation to and from clinic would be a very narrow downstream investment, social determinant of health, as opposed to safe and affordable housing, making sure a person doesn't live in a food desert, making sure they have access to early high quality childhood education, or freedom from racism or other forms of oppression. What is your educational process with your health systems to say, okay, what is upstream, what is a social determinant of health, to try to sort of move the needle further upstream and towards the forces that actually operate outside the healthcare system?
It's great. Amy, you want me to take this or?
Go for it, sure.
Excellent question. We specifically crafted guidance to require hospitals to differentiate between the two. We formed a work group to help inform the reporting requirements of a narrative document that we'll begin collecting from the hospitals when their spending floors roll out. And so we have separated social determinants of health into two categories. One, the more narrow focused, as you described it, we've dubbed social needs. And so that's the type of spending that would be like the transportation assistance. It would also be like housing vouchers and things of that nature, health related services for CCOs, right? And then we've also specified the category that is that broader upstream care that we want to have identified, give examples of what that type of spending is, the advocacy work, and the things that are much more focused in a population approach versus an individual approach.
And just to add, we've also specifically addressed the housing example that you gave, since that's an area where some health systems have been leading nationwide in community benefit. And we addressed that by saying that if there was a large one-time expenditure that a particular hospital was involved in, that we have a mechanism for spreading that over multiple years. So there's no disincentive to large one-time investments like that.
That's great to hear. Thank you. Brenda?
So thanks for that, Stephen. I'm curious, just to take it one step further, if the reporting requirements basically calls out the kinds of investments that are outside of the system walls or outside of the hospital walls, and those that are sort of the costs that are being captured within the system itself.
I think so. Let me. I think I know. I know what you just asked me. Hospitals are to speak to the extent of where they spend and how they spend. On that slide we showed earlier from 2007 forward, we've always had a detailed reporting program that just reported the costs. It was always just a transparency, like this is how much spending happened in Oregon, and didn't have a lot of outcomes per se to it. And within those requirements, by nature, it will designate what's going outside the hospital, what's going into community groups, what's going into community buildings, so to speak, versus what's activities that happen inside the walls, such as health professions education, or just the unreimbursed Medicaid. All that stuff is by virtue of operating the hospital. And so our program is set up that it can it can differentiate between what occurs within the four walls, so to speak, of a hospital, versus where is it going out into the greater community. And then the value add we added was requiring a new detailed narrative where a hospital has to, write up a full report that really explains their community benefit program, how they assess their needs, who's they've partnered with, what community groups, money and support's going out to, and things like that.
That's a great distinction. Thank you, Brenda. John?
Yeah, well, I just love the work you're doing. I'm just sitting here ruminating. So, insurers oftentimes in their contracts will require that healthcare providers collect co-payments because they are using that as a way to drive down utilization. So how are the insurers reacting to that? So for example, if someone who's at 300% of the poverty level had a $5,000 co-insurance amount, and the hospital was willing to write off 50% of that, I assume the law makes the insurer accept that decision. I wonder if it also makes the insurer count that towards an out-of-pocket limit. You follow me?
I am following you. I think without necessarily comment on specific future of policy, what House Bill 3076 did was shift the burden to the hospital in this population, right? In terms of that whole realm that you're speaking with, the hospital is the one that this whole world becomes charity care, right? If there is a deductible obligation, it's the hospital that takes that loss, that lack of collection. And that's kind of the bottom line of the outcome of that bill. I don't have the bill in front of me, but I think there is compliance language in front of it or associated with it that for that mechanism of forgiveness to exist within those that actually do have insurance and still need the financial assistance.
Thank you. We should wrap this up because I want to give our public comment one more try and work out any technical difficulties we have. Thank you so much for the presentation and discussions. It's a great program.
Thank you.
So Deb Elder, I see you on the screen, on the participant list. Let's see if we can unmute
Hi there, yes, I'm here.
Great. Okay, welcome. Sorry for the technical challenges. We look forward to your public comment. And you have 2 minutes, please.
Thank you so much. I have been listening in on your comments and projects that you're working on, and I can tell that we have some really amazing people who are committed to the health of Oregon, and thank you for that. But what if somebody said to you, we elect to not treat you, that's just our choice? And that was the leading infectious disease hospital that serves 500,000 people in Oregon. That's the reality here. I was one of 3 authors of Senate Bill 916 in 2015, and that was a massive effort where we brought forth patients from all over the state, and we told you what was going on. It got out of committee and onto the floor, but there is a ton of data that was submitted about Lyme disease 7 years ago. It's on the record. So we need to look at Senate Bill 916 and see that it had a clause in there that allowed MDs to use the ILADS, ILADS, or the International Lyme Disease Associated Society patient treatment guidelines. The problem that we have right now in Oregon is that we have absolutely no medical doctors who are diagnosing and treating Lyme. And in fact, many of them give a false diagnosis, a false negative to patients who go on to develop MS, fibro, chronic pain, neurologic distress, and cardiac events like I did. I have been to Washington, D.C. I have talked to Susan Collins, who is one of the authors of the TIC Act. We have brand new federal regulations on Lyme disease. We also have the CDC, which has updated their patient treatment guidelines. And those were always intended as a general guidelines, not a finite one. And it has been abused in the state, frankly. We have patients here who, there are 0 MDs in the state who are diagnosing and treating because your doctors here are scared to death they're going to get sued and lose their medical license. You know, if you want to know who said we elect to not treat, it was Peace Health Infectious Disease Unit. And I'm sitting here listening, talking about tax relief. Isn't it a violation of their federal tax relief to not provide care to people with infections? We know that children are born sick with congenital Lyme disease. That is also currently on the CDC website. So as part of a screening for women while they're pregnant, they should be diagnosed for Lyme disease and tested. We know that 50% of our patients commit suicide. If we really want to get our arms around suicide, we should be looking at this. Schizophrenia is also linked to it. We need medical doctor training in the state. We have to have a public education program. I'd really like to ask that you folks put together a group to properly address Lyme disease in the state and bring my nonprofit agency aboard to advise you. I would be more than happy.
thank you very much for
To help.
bringing your thoughts and your concerns to us. We don't have the forum here to act on it specifically, but we appreciate you sharing your concerns. And we think.
Would you please enlighten me on who would the decision maker be that I should approach?
Deb, I think this is a great forum for you to share your thoughts for the board and for our committees to be able to understand and include in consideration. We can always take this back and better understand where the best decision maker would be for this information specifically. And I think what David is just speaking to is that, you know, without preparation for this, we can't make decisions right now on anything that's brought forward in public comment, but that doesn't mean that we can't consider it in the future.
Right. And that's pretty much my overall request, is that we do form, you know, somewhere in the state, there has to be a medical group that we could create that would look at this issue. We could bring the East Coast regulations into the state and alter the terrain here so that patients would get care.
Thank you very much. So I'd like to thank all the staff at OHA for great preparation for this meeting, and each board member for the discussion. Really enjoyed our time together today, and we'll look forward to corresponding with y'all during the month and seeing you next month. So have a good day.
Thank you.
And take good care. Bye, everyone.